Hello everyone, welcome to the session Precision Medicine in Neurology. Our first presenter is Professor Efthimios Dardiotis, and he's going to present us biomarkers for Alzheimer's disease, clinical needs and applications.
Good afternoon. Thank you very much. Thank you, Professor Drakoulis, for your kind invitation. We are very honored to be part of this session, and also thank you for the collaboration which has brought us some beautiful papers. So the topic of my talk is the various clinical needs we have as clinicians in our clinical practice and how current and future biomarkers may help us in our decision making. So here is an overview of my talk. First, I will talk about the diagnostic biomarkers, those biomarkers that may help us in the diagnosis of the disease, the early diagnosis, and the conversion risk from the asymptomatic forms of Alzheimer's disease, and also they may help us in the differential diagnosis of Alzheimer's disease. Then we have another group, the severity biomarkers, that may help us in staging the disease and have the patient follow up for the assessment of the progression of the disease. Also, we need biomarkers to assess the therapeutic response of various medications that are available nowadays, either the efficacy or the toxicity. We also need predictive biomarkers in order to assess the risk for the disease in normal population. And then I will refer to some ethical issues and other needs. So with regard to the diagnosis of Alzheimer's disease, we should consider that Alzheimer's disease represents a clinical pathological continuum starting at sometimes even 15 years before the onset of the clinical symptomatology. We have accumulation of amyloid plaques. So we have a silent, progressive accumulation of amyloid plaques, of toxic products in the brain parenchyma. And after some time, these amyloid plaques trigger neurodegeneration, neuroinflammation, and then we have synapses loss, synaptic dysfunction, and neuronal loss. So during this course, first we have some subjective symptoms, and then we can have some behavioral symptoms. We have the mild cognitive impairment, we have symptomatology with the cognition, and then we have the clinical symptomatology of Alzheimer's disease, and the progression thereafter is very rapid. So the definitive diagnosis of Alzheimer's disease is based on the sensitivity of the criteria we use. For example, you can have a post-mortem diagnosis of Alzheimer's disease. We can have the clinical diagnosis of Alzheimer's disease at this point, and we can move forward and using the biochemical diagnosis, using some biomarkers, we can have the diagnosis of Alzheimer's disease earlier in this continuum, in this course. So there is a shift from the pathological diagnosis of the disease in autopsy cases, using the Braak staging and the burden of amyloid plaques and the neurofibrillary tangles. And then we have moved to the clinical diagnosis of Alzheimer's disease based on specific criteria, the criteria for the dementia, the criteria for Alzheimer's disease, and the clinical criteria for the mild cognitive impairment where there are some symptoms and the neuropsychological tests confirm this symptomatology. And also these are the proposed criteria for mild cognitive impairment. We have behavioral changes, and these are the proposed criteria. And now we have the biochemical diagnosis of the Alzheimer's disease, which is based on some biomarkers due to the ATN system, which stands for the A for amyloid biomarkers, T for tau biomarkers, and N for neurodegeneration. So these are the biomarkers we use in the diagnosis of Alzheimer's disease. First, with regard to the amyloid plaques, we can have the amyloid PET, which detects the amyloid plaques, the tracer binds to the amyloid plaques, and you can have a beautiful picture of the burden of the disease, for example, in this individual. We can also detect the A-beta in the CSF, in the spinal cord, in the fluid around the spinal cord, and by measuring these substances, we can have an estimation of the risk for Alzheimer's disease. Also, with regards to the tau pathology, we have the respective tau PET and also measurements in the CSF of phospho-tau. And finally, for neurodegeneration, we have the structural MRI scan. We can also have the FDZ PET, which give us an impression of the synaptic loss, and also we have measures in the CSF of the neurofilaments and the total tau. So based on this ATN system, Alzheimer's disease diagnosis we have only if we have evidence of A plus, of amyloid plus, and also T plus, regardless of the N, regardless of neurodegeneration, the presence or the absence of neurodegeneration. If we have only plus in the A, in the amyloid, and minus in the T, these represent only amyloid pathology without evidence of diagnosis of Alzheimer's disease. So by using these criteria, we are nowadays managed to have an earlier diagnosis of the disease. Here in this continuum, the clinical diagnosis comes at this point. So if we have the ATN system, we can have the diagnosis here when we have A plus, T plus, and N minus. So it would be very interesting in the future if by using future biomarkers we can move this early diagnosis in much earlier stages of this AD continuum. We can understand the importance of early diagnosis of Alzheimer's disease now that we are in the era of the new DMTs, the disease-modifying treatments. We have monoclonal antibodies that target the amyloid plaques in the brain. So the earlier the diagnosis, the better, because these individuals might have access to new drugs in order to slow down the disease, or delay the onset of the disease, or even prevent the advent of the disease. Another group of biomarkers that may be used in the future are those that may help us estimate the progression risk in the asymptomatic period of Alzheimer's disease. Before the early diagnosis, these individuals have in their brain some amyloid plaques, some tau proteins, but they are asymptomatic. So based off the levels of some specific biomarkers, we can have the conversion risk to AD. And it is important to discriminate which individuals are at higher risk for having a diagnosis of Alzheimer's disease later on in their life. So some challenges in the diagnosis of Alzheimer's disease is that some individuals have long prodromal stages. Also, the variability in the clinical phenotype, we have some phenotypes, not only the memory problems, but with some visual symptoms, which is atypical for Alzheimer's disease patients. We have also the language variant of Alzheimer's disease, problems with their speech, which is atypical again for Alzheimer's disease. And also you have the behavioral variant of Alzheimer's disease. Also you have AD mimics and comorbidities. This ATN system help us in the diagnosis of Alzheimer's disease versus the other AD dementias. However, there are plenty of dementias. So we don't have any biomarker for these dementias. For example, the DLB, the dementia with Lewy body, and other synucleinopathies, Parkinson's disease, dementia in Parkinson's disease, and MSA, multiple system atrophy. So a good candidate for these dementias may be asynuclein. Also, you have the frontotemporal dementia, which is characterized by behavioral problems, and these individuals don't have problems with their memory. So a good biomarker candidate is this protein, TDP43. We have the vascular dementia, we have the Creutzfeldt-Jakob disease with the elevation of PRP protein, and other mixed brain pathologies, for example, DLB with AD, co-pathology versus AD, or vascular dementia versus AD, Alzheimer's disease, with some evidence of cerebrovascular disease. So moving on to another category of biomarkers, we need severity and prognostic biomarkers. Let's see this picture. For example, it will be very important at some point in this continuum in our patients to have an estimation of the burden of the disease at this point and have a regular follow-up of this biomarker in order to assess the progression, the longitudinal progression of this individual. And also we need prognostic biomarkers to have an estimation, a number, a level of a biomarker at a specific time point in their lives, and we can predict the course of the disease, either fast progressive disease or slower progressive disease. Actually, nowadays we're able to have a gross staging of the brain problems in these patients using the amyloid PET scan. For example, you can see the different stages in these individuals. These are the asymptomatic. Here we have the mild cognitive impairment, and here we have the dementia cases. We can see that the peak accumulations happen somewhere here, and this is a drawback of this staging because then we have a ceiling effect. No difference in the later stages of the accumulation of alpha-beta plaques. Also, you have the tau PET with these beautiful images, and also we have the synaptic function with FDG PET. An interesting question in the literature is whether by using plasma biomarkers, we will be able to predict the amyloid PET and tau PET stages. So these researchers addressed this question, and they used a relatively large number of participants. Some of them were cognitively unimpaired, some of them had MCI, and some of them had dementia, and they used this bunch of biomarkers, A-beta-42 to A-beta-40 ratio, phospho-tau, GFAP, which is a protein that comes out after the destruction of astrocytes, and neurofilament-light protein, which is a protein that is the result of axonal loss of the neurons. And in this study, they found a fair good correlation between the changes in the plasma biomarkers with the PET scan staging of the disease. However, there is still room for improvement in order, for example, to translate the group-related results. In the previous study, we have some results from the whole group. So we have to translate these results into individual level results with specific cutoffs in order to give us the opportunity for measures and decision making. So maybe a hypothetical scenario for future validation and implementation of plasma biomarkers will be like this. These are some individuals, for example, and by using plasma biomarkers, we will be able to discriminate those with low risk of Alzheimer's disease and those with higher risk of Alzheimer's disease. However, some individuals may fall into this uncertainty category with, and then in this category, additional tests may be needed, for example, PET scan, only in this group in order to discriminate if they fall to the first or the second category of risk for Alzheimer's disease. Another important use of biomarkers that we need in the future are those that help us discriminate the prevalent pathology in Alzheimer's disease, either the amyloid pathology, if it is prevalent, or the tau pathology, if it is prevalent. And we can understand that in an individual with high pathology of tau protein, these individuals are not good candidates for the monoclonal antibodies that target the A-beta, and you can understand that. And also, these antibodies, the alpha-beta antibodies, should be given only in patients with low or intermediate tau pathology. So another important part is the prognostic proteins at a specific time point to have some levels of some biomarkers and may help us to make some future predictions of our individuals. However, alpha, beta, and tau biomarkers are not good candidates because of this ceiling effect I told you before. Maybe biomarkers and proteins of synaptic plasticity and synaptic proteins, for example, neurogranin, are good candidates because of the dysfunction or loss of synapses, and there are some good results in the literature showing that they have some kind of good prognostic value in order to predict the course of the disease. Moving on, we need also biomarker to assess the therapeutic response, either efficacy or toxicity, and this is an example of an individual before and after the use of the monoclonal antibody. We can see the clearance of amyloid plaques. So we need biomarkers in order to assess the therapeutic response. We know that many clinical trials in Alzheimer's disease have failed because they did not show some meaningful clinical results because they recruited patients with advanced stages of the disease. So the clinical phenomenology was somewhere at the same time in the group of the medication and in the placebo. So it will be very useful to have some biomarkers as surrogates of the clinical efficacy. And amyloid is not a good surrogate because here, after the clearance of amyloid plaques, the researchers didn't observe some kind of improvement of clinical improvement of this individual. So we should choose other biomarkers that have a good correlation between the clinical change and the levels of these biomarkers. Finally, we need predictive biomarkers to assess the disease risk in normal population, DAXI, which is very important. Alzheimer's disease is a multifactorial disease that almost 40% is attributed to modifiable risk factors, and 60% is attributed to genetic factors. And this is the complex genetic landscape of Alzheimer's disease, based on the of many trials or many studies trying to detect the genetic variants in Alzheimer's disease. So we have common variants, less common variants, and rare variants, other risk variants or protective variants. And it would be very interesting in the future if we can have an individual risk score using some kind of calculator that incorporates, for example, physical activity or inactivity, diabetes, level of education, hearing loss, which is an important risk factor for Alzheimer's disease, although it's not well known, traumatic brain injury, history of traumatic brain injury, hypertension, alcohol use, obesity, smoking, depression, and social isolation. And also this calculator may use also the genetic background of the individual. So every individual will have a specific score which can motivate those with higher risk for developing Alzheimer's disease to have some protective measures or to participate in clinical trials, for example, or have an early access to DMTs, or to have a closer follow-up for early signs of developing the Alzheimer's disease. Finally, there are some ethical issues with regards to the biomarker use, especially in research studies, and whether biomarker results should be disclosed to research participants. There has been much debate about that, and we should admit that if we disclose the level of amyloid plaques of a specific individual and possibly the likelihood of developing Alzheimer's disease, this may cause some kind of discrimination, of stigma, psychological stress to the individual. Also, it may change the access to the healthcare system and their ability to have some life insurance or their decision for employment, for driving, for independent living. So going through the literature, I saw that this kind of disclosure is justified in participants with cognitive impairment, those with cognitive impairment, provided that the results are valid. There are some kind of validation, not just a specific research study. So valid results, interpretable results by the clinician, and also actionable in the sense that this individual may participate in clinical trials or have access to modifying DMTs, monoclonal antibodies, and also have some modification in their lifestyle or future planning. So with all this information regarding the diagnosis of Alzheimer's disease, also with the use of biomarkers, the interpretation of biomarkers, and given that in the following year we expect a tremendous increase in the cases of Alzheimer's disease, we desperately need experts in the field of dementia, of Alzheimer's disease, neurologists, that have a specific training in Alzheimer's disease in order to interpret all this information and implement all these new drugs and help us in our decision making. So thank you very much. This was my talk with regards to the biomarker use.
Thank you, Professor Dardiotis. Any questions?
Yes, there are nowadays, we expect from the authorities, from the EMA, two medication, the lecanemab, which shows some kind of 29% difference in the response in the placebo drug and the positive arm, and another monoclonal antibody had a much higher efficacy, the donanemab, which was in 34. However, there are some differences between these two medications with regards to the side effects. The side effects, either the bleeding or the edema in the second drug, the most effective drug, was higher compared to the first one, the lecanemab. So we expect what the authorities will tell us about how we will use, which are the best candidates for this medication, and of course we should try to give it in the early stages of Alzheimer's disease, in order to have them in the strict follow-up and have them with MRI scan every month, every 3 months, and it will be tough to observe these individuals. However, I think this is the first step, and then maybe in the future more drugs may be in the field, so we'll be able to use them. Thank you.
Thank you very much, Professor Dardiotis, again. So we are moving on with our next presentation from Professor Leonidas Phylactou from the Cyprus Institute of Neurology and Genetics. And the title is The Role of MicroRNAs in Signaling and Use as Biomarkers in Myotonic Dystrophy Type 1. Thank you.
ευχαριστήσω πρώτα απ' όλα τον Νίκο Τρακούλη, την Επιστημονική και την Οργανωτική Επιτροπή που με προσκάλεσα και μου έδωσαν την ευκαιρία να σας παρουσιάσω κάποιο μέρος της δουλειάς του εργαστηρίου μας. Ένα κομμάτι του εργαστηρίου μας ασχολείται με τους μυς, με τις μυοκικές δυστροφίες και ιδιαίτερα με την μυοτονική δυστροφία. Πιο συγκεκριμένα προσπαθούμε να βρούμε δείχτες στο αίμα microRNA που συνδέονται με τη μυοτονική δυστροφία. Θα γυρίσω στα αγγλικά. Also trying to see the relation between microRNAs and tissue communication. And finally, we try to develop extracellular vesicles as therapeutic vehicles for delivering drugs in the muscle. Today, I will try to focus on the first two. Let me just start by saying a few things about myotonic dystrophy. Myotonic dystrophy is an inherited disease. It belongs to the family of muscular dystrophies. It is the most common form of muscular dystrophy that develops in adults. It affects approximately 1 in 8,000 individuals globally. And the mutation is an expansion of a trinucleotide repeat CTG, which is located in the 3' untranslated region of the DMPK gene. I wouldn't even bother going through every letter of the gene because it's not so important. What is important, the protein is not so important. What is important is the RNA. And the reason being is that it is in the untranslated region, as I said. Therefore, the mutation is not present in the protein. It's present at the DNA, at the RNA level. Now, as I said before, it is an inherited disease. It's transmitted in an autosomal dominant mode. And it has an increasing severity through generations, a phenomenon called genetic anticipation. Now, leading from where Efthimios has very nicely left it with the biomarkers, there is need for biomarkers at all levels, diagnostic level, prognostic, monitoring the disease, and also for assessing drugs. In the case of myotonic dystrophy, there is need also because it is a progressive disease and there is a heterogeneity between patients. So our aim was to see whether we can identify microRNAs in the serum of patients with myotonic dystrophy. We collaborated with several centers on serum samples, and the first thing we looked was four microRNAs which are known to be specifically expressed in the skeletal muscle. And we have shown that all four microRNAs were increased compared to healthy individuals in all four microRNAs. We then grouped the patients between those that exhibited progression or stable patients. And again, we showed that those who were progressive, the levels of the four microRNAs were even higher compared to those that had a stable case. Now, we then tried to see about the ontology of these microRNAs, because these microRNAs do circulate in the blood, since those detections happen from serum samples. And we looked at different methods to see about the ontology. And we ended up with extracellular vesicles. Extracellular vesicles are bodies, like small cells, that are secreted by cells. And in many cases, they do carry important information, and they do result in secondary tissues. And in several cases, they are involved in the signaling, the communication. Now, what we did is that we extracted, we isolated extracellular vesicles from serum samples of patients with myotonic dystrophy, And we, first of all, we characterize them. We characterize them by electron microscopy, just to make sure that we did isolate these bodies. We immunogold labeled them with proteins that are specific for these vesicles. We also did Western blotting showing specificity. Then we did exactly the same exercise. We took the samples from patients, extracted for vesicles, and we saw similar results. We saw that all 4 microRNAs were increased in the patients compared to the healthy individuals. And similarly, those patients that were in the progressive mode had higher levels compared to the controls. Now, the next thing we wanted to do is, again, with the help of collaborators and biobanks, try to look at, to follow the progress of the patients. So we did collect several samples from patients with between different visits from their doctors. So we did have we do have a collection of 2 visits or a collection of 3 visits. And these are well characterized by international standards, and therefore we can follow this for the first time, these 4 microRNAs and see what happens. So these are from 2 visits. Obviously, in the visit A, we don't know what was before, so we cannot really characterize. But we can tell that in the case of stable patients between visit B from A, the levels were pretty much similar. Whereas in the case of patients that were progressive, degenerative patients, we could see an increase in all 4 levels. We then switched to the triple visits, we started first with the patients that were stable, and then they remained stable, and we could see a stability in the levels of 4 microRNAs between these patients, between visits. Similarly, those patients that were progressive and then they became stable, again, their microRNA levels of those particular 4 microRNAs stabilized as well. Whereas in the case of patients who were stable and then they got worse, they became more progressive, we could see a big increase in the 4 microRNAs. And similarly, patients that were progressive and remained progressive, again, there was an increase on the microRNA levels as well, which shows that these 4 microRNAs seem good markers to follow the progression and associate with the progression of the disease. Now, these are just some more examples, individual cases. I won't spend a lot of time just for the sake of saving time. So again, cases of stable who remained stable, stable who became progressive, progressive who became stable, progressive patients who remained progressive, and some logarithmic associations as well, which show a similar thing. And you can see the trends in the progressive here, 1 and 3, compared to the stable. We also did, in parallel, some deep RNA sequencing on samples. We identified some more microRNAs in the serum of these patients. So we have in front of us some more microRNAs now that show a similar association, increased levels compared to healthy individuals, as you can see here. We also test this in the myotonic dystrophy, one of the myotonic dystrophy type 1 animal models that we got from Paris, and this result is also confirmed in mice, in the blood of mice. We are now identifying also prognostic biomarkers. These are microRNAs that were detected at the beginning of the course, and we tried to see whether the levels at the beginning reflected the progression of the disease. And we do have some preliminary results. For obvious reasons, I couldn't put the numbers of the microRNAs, and you can see microRNAs that have low levels, and this reflects stability for the future, and also some microRNAs that had increased levels at the beginning, and that reflects the progression in those patients. Now, the last part of the talk relates to a bit more basic research. So obviously, microRNAs circulate, and it is known that there is communication between tissues through microRNAs. And this is what it seems we are evidencing in our case as well in the case of muscles. So what we did is that we switched to the mouse, wild-type mouse, and what we did is that we threw from different muscle types, we isolated extracellular vesicles that were about to leave the muscles. So we isolated EVs, the microRNAs from EVs, and we could see that these microRNAs basically are located within these extracellular vesicles in different types of muscles at different levels. As a next step, I will show some very brief results. As a next step, we try to interfere with this, and what we want to see is the communication between tissues, muscle tissues, and so we interfere with these microRNAs at the beginning. We injected tibialis anterior muscle, the TA muscle, with an antagonist. This is an antisense molecule against a couple of these microRNAs, the microRNA 133A and B, and you can see the big reduction in the levels compared to controls. And then we observed a good decrease as well in the microRNA levels in the extracellular vesicles that left the muscles. So this reduction here then followed in the presence of the low presence of these microRNAs in the extracellular vesicles. So we did a similar detection for other muscles now as well, and we showed that this initial interference with the microRNAs, the reduction of microRNAs in the TA muscle resulted in a decrease in other muscle types as well, as you can see here at various levels, indicating the possible communication of these microRNAs to neighboring muscle tissues as well. And finally, I'm showing you here also, we detected these microRNAs at the serum, and one could see that following the reduction through antagonists in the tibialis anterior, there was a decrease in the overall microRNA levels in the serum as well. So these are just some snapshots from the work that the PhD student has done in my lab. Now, conclusions, we believe that microRNAs can be possible, good candidates as biomarkers for the disease, especially for the progression of the disease, which shows big heterogeneity between patients. Definitely, we have detected microRNAs in the EVs, and this might be implicated in the disease, in the pathogenesis of the disease as well. And it is a possible mechanism that can explain some of the symptoms of the disease, because myotonic dystrophy is not only a muscle disease, a multisystemic disease, but overall microRNAs seem to be tools and molecules that enhance communication between muscles. These are some of the people that have helped us. We have various collaborations, both within CING and outside. I would like to thank the funding, and especially the Telethon of France that gave us multiple grants for this work. And finally, to thank our people that work towards this. And this is a picture of our institute in Cyprus, that I'm also the director of it. Thanks very much.
Thank you, Professor Phylactou, for your beautiful study. Any question from the audience? So I would like to ask you if there is any pathogenicity of these biomarkers, or they just represent some biostandards that we detect during the process of the disease. Is any pathogenic role for these microRNAs? For example, if we eject them, these muscle may develop some kind of myopathy.
I think nobody knows, but it's for certain yes, because microRNAs are involved so much in the regulation in any kind of reaction in a cell. So I would assume yes, and since there are many different pathways that are involved in myotonic dystrophy as well, I believe
maybe
they
in
are.
The future, will these biomarkers represent some targets for the pharmaceutical companies in order to target the microRNAs? And
Yeah, there are a couple of attempts as well so far that have shown promise by targeting certain microRNAs and showing good results for myotonic dystrophy, yes.
So we have in our department a lot of DM1s, so very be good if we have some kind of collaboration.
That's the good thing about meeting in person
Yes.
in meetings. So definitely, we'll get in touch. Thank you.
Thank you, Professor. So moving to the next speakers. Next speaker is Vasilis Siokas, and Vasilis is elected Professor of Neurology in Larissa, and he will tell us about the application of transcranial magnetic stimulation in neurology. Vasilis has a good expertise in this field. He was abroad for more than 1 year, testing these appliances to patients with stroke and trying to improve their symptoms. So it will be some type of helping people to have a more rapid gain of what they lost during the stroke. Vasilis, the floor is yours.
Hello, thank you, Professor Drakoulis, for the invitation to speak in this Congress. I will present you the future treatment option for transcranial magnetic stimulation, for now on TMS in neurology. And I'm going to do that in the next 15 minutes by presenting the current knowledge about TMS in neurology, the gaps that exist, so that we can understand what to expect in the future for this method. TMS is based on Faraday's law of electromagnetic field, when an electric current is discharged into a TMS coil, creating a vertical magnetic field, which transcranially and non-invasively reaches the brain. These electric fields and the electric currents that are created in the brain tissue alter somehow the brain function. And these fields, these currents, depolarize neurons and result in measurable action potentials. These measurements can be done with EEG or with motor evoked potentials, or indirectly with functional MRIs. The TMS targets the cortical areas in the central nervous system, and by applying the various modern neuronavigation system, but even without them, but with less precision, of course, we can target and stimulate the areas of the cerebral cortex that interest us based on each protocol. It is a non-invasive, safe, and painless procedure. Of course, for the safe application, a deep knowledge of mechanism and techniques is necessary, and also the safety rules must be followed. Another thing that we have to keep in mind is that by increasing the intensity and the duration and the frequency of the stimuli, and by decreasing the breaks between them, the chances of side effects increase. There are several ways regarding the frequency and the pattern that TMS can be applied. As a general principle, the single TMS has mainly diagnostic applications, e.g. by measuring an index, we can examine if and how it is possibly related to a phenotype, e.g. oscillations in the brain and the prediction of delirium in stroke patients. And while the repetitive TMS has mainly therapeutic applications. Here we see that how high-frequency TMS is applied to increase the excitability, while the single TMS reduce and inhibit the excitability. The rationale for applying repetitive TMS for the treatment of neurological and psychiatric disorders is based on the hypothesis that simulation can alter brain activity and physiology. Those functional abnormalities that are believed to cause these neurological deficits could potentially be compensated or even reversed. Up to now, there is level A evidence for the effectiveness of high-frequency rTMS in neuropathic pain, depression, as well as for the application of low-frequency TMS, contralational in hand motor recovery after stroke. There is also level B evidence for fibromyalgia, lower limb spasticity in multiple sclerosis patients, post-traumatic stress disorders, chronic non-fluid aphasia after stroke, and motor impairment and depression in patients with Parkinson's disease. There is also some evidence for hand recovery after stroke, for motor stroke, but with different protocols than those that have a level A evidence. The absence of level A evidence or level B evidence for other neurological diseases does not mean that these are excluded from TMS application, nor that there is no therapeutic benefit. So let's take a look at the current data for some of the most common neurological diseases. For multiple sclerosis, apart from lower limb spasticity, for which, as we have seen, there is a level B evidence, TMS appears to have some beneficial effect on other clinical manifestations, namely the upper extremity spasticity, the cerebellum dysfunction, the urinary tract dysfunction, the cognitive decline, the depression, and the fatigue. For Alzheimer's disease, high-frequency rTMS in a more holistic approach is particularly interesting with a combination of TMS with cognitive training, where this combination seems to be more beneficial. This is in particular interesting in patients with mild early stages of AD and even in patients with mild cognitive impairment. Regarding the other forms of dementia, like frontotemporal dementia or vascular dementia, research is still in the preliminary stages and large randomized studies are currently lacking. Regarding Parkinson's disease, we have already discussed the high-frequency repetitive transcranial migraine simulation to either primary motor cortex or to the left dorsolateral prefrontal cortex, improve motor function or depression, respectively. Considering this data so far, we can say that the repetitive TMS can have a potential therapeutic role in Parkinson's disease for motor function and for depression. For the rest of the movement disorders, the benefit for rTMS appear to be small and not fully proven. For example, the stimulation of supplementary motor area in Huntington's disease or the application of low-frequency repetitive TMS in the cerebellum and pre-supplementary motor area for tremor can be beneficial. But overall, the available data for the movement disorders expect the Parkinson's disease are very limited. For amyotrophic lateral sclerosis, the rationale for RTMS is to reduce cortical hyperexcitability and thereby counteract excitatory toxicity from glutamate and other neurotransmitters, which are thought to be involved in the disease mechanism. Studies are relatively limited in the number, and there is insufficient evidence for the effectiveness of RTMS in ALS. Considering epilepsy, the rationale for the application of RTMS in epilepsy is to modify focal cortical hyperactivity, which is thought to be a central mechanism in epileptic seizure. Data from the few RCTs suggests that repetitive TMS is safe, and also there is a reduction in EEG abnormalities after RTMS, but the latter does not necessarily mean therapeutic efficacy. Regarding migraine, one of the most common neurological disorders, studies have shown that RTMS does not reduce the frequency of migraine attacks. However, single pulse can be applied for migraine prevention. But what about stroke? We have already seen the slide demonstrating the application of high-frequency RTMS to the site of the lesion to increase excitability, while low-frequency application contralateral to the lesion inhibits the unaffected hemisphere. The rationale for applying these protocols for stroke is derived from the fact that increased excitability of the undamaged hemisphere, it is thought to block recovery after stroke in the damaged hemisphere. The majority of studies have targeted motor deficit, aphasia, neglect in subacute and chronic stroke patients. However, other deficits, such as dysarthria or dysphagia or depression in stroke patients appear to be improved after TMS. While of particularly interesting is a combination of both protocols, which means high frequency in the unaffected site and low frequency in the affected site. Here are the results from an fMRI study examining the connectivity between areas to the motor cortex. In figure A, we see that in the healthy people, when they move the right head, there is an enhancement in connectivity between areas of the left motor cortex, which means supplementary motor area, primary motor area, and M1. And there is especially more connectivity between SMA and M1. This does not happen in stroke patients, as we can see here in the figure B. And why this is interesting for us? Because we know that the mobility of the paretic hands depends on the connectivity between the supplementary motor area and the M1 area. And the enhancement with this protocol maybe between supplementary motor area and M1 area could be a potential therapeutic target in motor stroke. About the disorders of consciousness, although there is some clinical benefit for application of high-frequency TMS to the left M1 or for high-frequency TMS or TBS to the left dorsolateral prefrontal cortex in some people, due to the very small sample sizes of this study, there is insufficient data or evidence for the use of RTMS in these disorders. For tinnitus, repetitive TMS has been applied as a low frequency in the auditory temporal cortex of the left hemisphere, or to the contralateral or more affected ear, contralateral to the more affected ear. Other protocols have used the parietal lobe, the prefrontal cortex, or combination of these protocols. A relatively recent pilot study applied the stimulation protocol individually tailored to each patient. They used different techniques and targets, for example, the DLPFC, the TPC, during the first TMS session, in order to decide which is the most suitable one to continue for the next sessions. Those who received a personalized protocol had better outcomes than patients receiving a standard protocol. But what about the future therapeutic options for transcranial magnetic simulations? Let's see what we usually do in practice right now. We have a patient, we apply the TMS, and we observe the outcome after a time of period. But we don't know what actually happened during stimulation, and also we don't know what extent to what extent the outcome is the results of TMS. So we have to find a way to open the door and see what happens during the simulation. And the key is the application of TMS with simultaneous use of real-time EEG or fMRI or tractography, so that we can in the protocol, modify them and stimulate very personalized in each patient. This will lead to better knowledge of how the TMS itself related to the outcome. To summarize, there is a proven TMS proven safe and beneficial intervention with level A evidence for specific symptoms in specific neurological disorders. Although not a first choice, TMS may have an important place in improving symptoms and the quality of life of certain patients, particularly those unresponsive to other treatments. So what do we need in the future? Well-designed blinded RCTs with well-established predefined methodology, with specific and clearly predefined endpoints, with actually selected simulation parameters, e.g. the frequency and the intensity of the simulation, proper coil selection, as well as target and site of stimulation, but also with real-time data, if this is possible, in order to personalize and to adjust the characters of the simulation with the aim to have the great possible benefit for the patients. Taking into account that right now there is too many ongoing TMS studies, we believe that we can answer these questions about the therapeutic application for TMS to neurological disorders in the future. Thank you. There is situations like disorders like depression and stroke that seems very promising and very effective. For other diseases like Alzheimer disease or ALS, the data is not so good right now. But for stroke and depression, I think the data is very promising. Okay. Let's talk about stroke. For stroke, we can do even in the acute phase, even in chronic phase. It depends on the protocol and about the deficit that we have to cover.
Neurology, and especially in cases with headache. He has his master and PhD in headache, so he will tell us about the monoclonal antibodies, the individualized treatment that we have nowadays available for these kind of individuals with migraine. Michalis, the stage is yours.
Thank you, Themi. Thank you, dear colleagues, for being here. So that was a very kind introduction, but you are a very good friend. So I'm a neurologist by training. I'm only working with headaches, so I specialize in headaches. And I would like to welcome you, for those who don't know this field, to this new brilliant era of headache medicine. Till a few years ago, I would say that for most neurologists, it was not very interesting to deal with headaches because we had no many treatment options, and we couldn't do much for our patients. But since a few years ago, we have the introduction of a new category, the monoclonal antibodies against the CGRP pathway. And these are the medicines that you may have heard from patients are called like life-changing, miraculous, etc. So I will talk about these medications, and I will try to make a comparison among them to see if any of them works better than the other. So these are my disclosures. And just a brief introduction for you. So we have currently 4 approved monoclonal antibodies against the CGRP pathway in the European Union. 3 of them are available in Greece. It's erenumab, fremanezumab, and galcanezumab. 2 of them are humanized, while erenumab is a human antibody. They are all IgG2 category. And the main difference, we could say, is that erenumab acts on the receptor, while fremanezumab and galcanezumab act on the ligand. So they're administered subcutaneously once a month, and they're all approved in European Union for prevention of migraine. And they're reimbursed in Greece and throughout Europe for various categories of patients depending on the country. So we have now new medicines, and we have more than one. So how us neurologists can compare them? As a matter of fact, this is a little bit tricky because there are no direct comparisons among CGRP monoclonal antibodies. So we have to rely on more or less, first of all, indirect data. And this is a network meta-analysis published a few months ago. So in this meta-analysis, you may see all migraine treatments, including some that actually don't work, but they're still used in practice. And what you may see is that the authors found with high certainty that use of CGRP pathway drugs, like the monoclonal antibodies, erenumab, fremanezumab, galcanezumab, or gepants, which are small molecules against the receptor, this increases the possibility of a good outcome versus placebo to decrease migraine frequency. Also, and this was a very interesting finding for us that we knew it from clinical practice, the old school, like anticonvulsants like valproate or amitriptyline, which is a tricyclic antidepressant, highly increase the possibility of adverse event that could lead to discontinuation. So in this data, you may see that the ligand-performing treatments seems to work a little bit better than the others. And among them, fremanezumab, the one ligand targeting treatment, seems to be the best. The only direct comparison came to light a few weeks ago, and it is a direct comparison, a randomized trial comparing galcanezumab, a ligand targeting antibody, to rimegepant, which is a small molecule targeting the receptor. So we don't have direct comparisons of antibodies, but we have a comparison of an antibody against a small molecule targeting the receptor. So the authors went for the study. Eli Lilly funded the study, expecting that there would be a huge difference favoring the antibody, and this was not the case at all. As you may see, this is a primary outcome, the proportion of patients achieving at least 50% headache reduction, and the result is very, very much similar. So we have only one comparison of a ligand versus a receptor targeting treatment, and the result is similar. We should note, at least us neurologists like Themis and myself should note, that this is a short duration study, it's just 3 months, so this is number one. Second, in this study, 80% of participants were treatment naive. That means that were people that were given preventive treatment for the first time in their life. So this is not our population, because in Greece we can give these medications in patients that have failed all approved treatments. And not most of them, half of them had episodic migraine with low frequency. That means 7 or more or less days of migraine per month. And this is also not the population we use this medication in clinical practice, because AOP, our local authorities, only approve it for patients with 8 or more days per month. So just one study, similar results, not the population. So if there are no direct studies, what can we see? How can we compare? As I said before, indirect comparisons and data from real world. Real world are the studies that are conducted post-approval, and they give us, at some instances, very interesting input. Just a slide on pathophysiology. This is CGRP receptor, this is CGRP, but also CGRP acts at the amylin-1 receptor. As a matter of fact, CGRP and amylin are equipotent at the amylin-1 receptor, while CGRP is much more potent at the canonical CGRP receptor. The monoclonal antibody that targets the CGRP receptor also inhibits, also targets the amylin-1 receptor, and this also goes for the small molecules. So these medications, these drugs, actually block two receptors. And we can all understand this could be a positive factor if it leads to greater efficacy, could be neutral, or it can even be a negative factor leading to adverse events. Let's move to clinical data. This is studies from Italy for the three different antibodies. This is the receptor targeting, and these are the ligand targeting. And you can see that in chronic migraine and episodic migraine, they have more or less similar results. There are some numerical differences, but one can say, I don't see much of a difference. Still, we have data, like in this study, that they also performed sub-analysis, subgroups. And as you may see, this is the usually primary outcome, 50% response. That means my migraine frequency will be reduced by at least 50%. I will start with 10 days, and after treatment, I will have 5 days or less. So, similar outcome, similar results, but look at the super responders. This is what our patients want. We recently conducted, and I think Themis was also involved in a study of patient preferences, and our patients said, we don't need 50% reduction, we want more. 50% is not enough for us. So 75% reduction, we call them super responders. And there's a difference at a statistical significant rate favoring the ligand targeting treatment. And this imbalance can be also noticed here. The partial responders, 30 to 50%, patients are not happy with it, most of them. And here, the receptor targeting treatment performs better, gives better results. So it seems that these treatments don't work the same way for every patient. Another issue in clinical practice, maintenance of result. We give a treatment, we have some result, but we want to keep the result over time. This is a study from Denmark. Denmark, maybe you don't know that, obviously you don't know that, is the leading country in Europe for headache research. They have the biggest center, they produce the greatest papers. So they followed 300 chronic migraine patients for a year. And they saw that 71% were responders, at least 30%. I said this is not satisfactory for patients, but this is an outcome used for difficult cases like chronic migraine. Only a third of them were sustained at least 30% responders at all time points through this year. That means these patients were fluctuating between a good or decent response and a not so decent response. And these are data from the UK. We have an excellent researcher there, Anna Andreou, is a Greek Cypriot neurologist who performs excellent job in the UK. So almost at month 6, this is all patients using the receptor targeting treatment. At month 6, half of them could be considered as responders, but in 1 year, this goes to a third, and at 2 years, just a quarter of patients are responders. So clearly, there is some evidence that using the receptor targeting treatment does not produce a sustained effect. On the other hand, from data, from real-world data, studies using the ligand targeting treatments, you can see that at least for a year, there is a consistency of the effect at month 6 for fremanezumab, and at month 6 and 12 for galcanezumab, and even some numerical improvement in some outcomes. Another issue we face in clinical practice with headache patients is switches. So what if a patient using a CGRP pathway antibody fails due to efficacy or due to adverse events? What do we do? As a matter of fact, in Greece, where we work, initially, the public health authorities, the public insurance, did not approve a second antibody after failure of the first one, claiming they're all the same. The first one failed, no hope for the second one. And thankfully, this is not the case anymore, and real-world data supports this. This is a very nice study. We also tried to do something like this in Greece. This is an observational, prospective, multi-center study, 4-year design. So they decided to study patients starting fremanezumab for 4 years. And the first paper came from an interim subgroup analysis. So they said some of these patients before used the other antibodies. So how did they do at the beginning of fremanezumab treatment? As you may see, most of them used the receptor antibody, the receptor targeting antibody, erenumab, that failed. And in 85% of these cases, it failed due to efficacy. It did not produce efficacy. 43% were responders at 3 months. So after failure of the first antibody due to efficacy, the second antibody targeting a different point at the CGRP pathway produced better result. And this can also, of course, go the other way around. This is not as much good evidence. This is a small retrospective study with a very small number of patients. But yes, some patients, after switching from the ligand targeting antibodies to the receptor antibody, had some reduction. It could be classified as responders. So also the other way can work in some patients. And I'm moving on to safety. Just to remind you, pathophysiologically, that this could be the normal condition. And as you may see, if you block the CGRP, then you block the transmission both through the CGRP and the amylin receptor. Also, if you block the amylin receptor. CGRP is indeed an important messenger in the enteric sensory neurons because it when activated, these neurons, by mucosal stimulation, they initiate pathways that activate peristaltic movement, so bowel movement, and also water secretion into the lumen, into the intestinal lumen. And it seems, and you will see in the next slide why, that if we completely, not completely, we cannot block it completely, but if we inhibit the transmission both through the CGRP and the amylin receptor, we get some problem. And this problem is called constipation. These are data, the most recent published data from the FDA, the Food and Drug Administration in the US, a very important regulatory authority, that uses real-world data on adverse events. And you see the 4, because they also have the IV monoclonal antibody available there, the 4 antibodies, and you may see one difference. For the receptor targeting antibody, number 1 adverse event reported after circulation, after being commercially available, is by far constipation, which is not listed in the top 10 adverse event list of the other antibodies. So for sure, there is a different safety profile. And one could argue, what is the issue with constipation in real practice? I mean, you may not expect it that this could be a reason for a discontinuation of a successful treatment. This could be a reason that a patient that experiences a good reduction in his migraine will prefer to stop treatment and switch treatment. This is an important issue, and sometimes it needs to be medically addressed. It's not something, it's not just a discomfort. I would like to say that CGRP receptor targeting treatments, as again erenumab, the antibody that targets, may produce much larger numbers of constipation adverse events. This is the same study before from Denmark, 300 patients, 41% had constipation in this real-world data. And it's not only the case for antibodies targeting the receptor. These are data from a small molecule called atogepant. This is not yet commercially available in Greece. We expect it next year, I think. It will be used as a migraine preventive, so it will be used on a daily basis. And it produced at phase 3 trials constipation at a significant level. On the other hand, sometimes we can see it with ligand targeting treatments like fremanezumab at a much smaller rate. So I want to conclude with this slide. No, I have one more with my key messages. Just keep that in mind. So this is a systematic review. This was published in the best headache journal called Cephalalgia from another group from Greece, from the University of Athens. So they tried to evaluate the overall benefit to risk ratio of migraine preventive treatment. So this is what they did. They used data from phase 3 randomized trials. So they used hard data. And they calculated what we call number needed to treat. Are you familiar with this term? So nobody's familiar, almost nobody. So number needed to treat is a number that gives us the meaning is the following. How many patients do I have to treat so I get one with a desired outcome? How can we calculate it? For example, let's say that I use this specific treatment and it produces 100% result in the active group, but 50% result in the placebo group. The absolute risk reduction is 0.5. We take out 50% from 100%, and we say 0.5 is the absolute risk reduction provided by the medicine, because the other half could be attributed to placebo. And if we reverse it, we get a number. So a number needed to treat 2 means if I give it to 2 patients, 1 will get the benefit due to only effect of the drug and not placebo. The same way, we calculate number needed to harm. How many patients do I have to treat to get to 1 with a certain adverse event? So this is what they did. They calculated number needed to treat for a patient to experience at least 50% reduction in migraine frequency. This is the usual primary endpoint in clinical trials of migraine medications. And they used number needed to harm for a patient to experience an adverse event that will lead to study discontinuation. So a patient in this study will go out of the study, I quit because I have this adverse event I cannot stand. And these are the results. The results are impressive, favoring the antibodies versus the old treatments like anticonvulsants and beta blockers, which, due to poor tolerance, due to adverse events, due to the fact that in the studies of anticonvulsants, topiramate, a common anticonvulsant in migraine, there was a 25% withdrawal due to adverse events. And these are the results. This is the overall benefit to risk ratio favoring the antibodies, and especially the ligand targeting antibody. So, just a conclusion to this, I would say, maybe for some of you, very, very specific and not so interesting point of view. There is evidence that among these new treatments we have available as neurologists, there are differences. And we could say that between ligand and receptor targeted treatments, the effect is not the same in terms of efficacy, in terms of reduction of migraine frequency, in terms of sustained effect, maintaining our effect, but also for sure in terms of adverse events. Currently, in our country, we have the possibility to switch treatments, and we do that both ways in clinical practice. And we can also get some extra benefits, some more patients gaining benefit from this treatment. So this is the status, and we're also happy in migraine medicine. Thank you.
Thank you, Michalis, for presenting all this detailed information regarding the monoclonal use in migraine. Any questions, please?
Hello? Ναι, μ' ακούτε? Okay. Thank you very much. It is known that migraines are a disability, a very hard disability. I would like to ask if you have any feedback about medicinal lymphadenopathy.
Medicinal?
Lymphadenopathies, yeah, lymphadenopathy, from the monoclonal antibodies.
Lymphadenopathies.
Lymphadenopathies.
Well, there are very few reports on this. In general, our antibodies targeting the CGRP pathway produce an astonishingly low level of adverse events. So it's not anything compared to antibodies used for lupus, for autoimmune disorders, or for MS. I will say that there are very few reports, and the main adverse event profile includes constipation for the receptor targeting treatment and injection site issues with the other treatments, but not serious adverse events, not many adverse events leading to discontinuation, some wane gait over time at the long term, and some cases of hypertension, again with a receptor targeting treatment.
Okay. So you have some estimation about how long times can a patient be under this treatment?
So this is a very interesting point of view. Patients that started in 2015-16 with clinical trials, they extended use, so there is a limited experience with patients having started almost 10 years ago. We started in Greece in 2017 with around 10 patients participating in phase 3 trials, and most of them are still on and off on this treatment. So overall, there is no signal of additional adverse events at the long term except for hypertension I told you before. And overall, this is a treatment that most patients don't want to stop. No. There were recent statistics in the International Headache Society that attended the Congress earlier this year. It is estimated that around 70% will relapse within 6 months after stopping these treatments. So maybe a 30% regains, has an effect after stopping. Most of them will relapse, and patients will come asking for this treatment. It's not the other way that we are pressing patients to use them. The pressure comes the other way.
Thank you very much.
Michalis, have you ever seen in the patients, in your patients, any kind of wearing off of the subsequent injections of the monoclonal antibodies, so they progressively lose their efficacy in the subsequent injections?
Yes, indeed, this is the case for some patients. So I've seen it, and I've seen it mainly for Renumab, the receptor targeting antibody, sorry, but also for the ligand targeting Fremanezumab. So we have to switch treatment in these cases. There is also another interesting phenomenon that some patients do perform bad for a dose or two, so they can be very well for a year. Then we can see a relapse for a month or two for no obvious reason, and then you see then the benefit comes in again. So
some kind of rebound effect?
Some time of, but not a continuous rebound, not a permanent rebound effect. Some kind of losing efficacy for a month and then again working good.
Okay. We'll learn more in the future about that.
Currently, the public health authorities demand or ask for an interruption at 18 to 24 months. So this has started being the common practice. I don't know if you have noticed in your patients. The OP starts asking for our patients to try to stop treatment. And we're at this stage now with many patients, so we'll have many data on possible relapse in next year or something.
Okay, thank you very much. Thank you, Michalis.
Thank you, Themi.
Now we have a very short break, and please be back in 10 minutes. So now we're back. We will move to the next speaker, Dr. Alexandros Petrelis. Dr. Petrelis is the Director of Data and Analytics R&D at Micropep Technologies, Toulouse, France. It sounds very important, the affiliation. So. Okay.
Okay. Thank you. Thank you for the invitation from Professor Drakoulis. And here I can see the high quality of the high scientific quality, but at the same time very high technical and administrative quality. Just to mention that it's a really very well organized conference. At the same time I'm working in the industry. That's why the affiliation was in the R&D research and development in the industry, but in parallel I continue my passion in the medical research. So I was working in CERN, and I'm going to present you a study in the VEGF-A-related genetic variants protect against Alzheimer's disease. It took place in the gene-environment interaction cardiovascular physiopathology in Nancy, France. Under the supervision of Dr. Sophia Siest, that she will be available tomorrow, as she wasn't able to come today because of a flight that she missed. I'm going to present you quickly an introduction to Alzheimer and VEGF-A, then a hypothesis, methods, and materials, and I will conclude with the results. Just at the end, I'm going to present you two tools that it has been used for the study, but also it will be useful from a student level until a professor level or director of a hospital, how to handle data and have an overview of your data, of your analysis, etc. Just to make it clear, my background is mathematics, and I just discovered the biology the last years, and I love to be in the field. The dementia, it was more than 55 million people have been impacted from dementia, and more than 20.4 million deaths we have from dementia, and it put dementia in the 5th position based on the annual number of deaths. Also, it has a financial impact, more than $1.3 trillion in 2019, and social impact. So with this huge number, you can imagine this impact. And this is how I understand, maybe a quick introduction as I understand it. As Alzheimer's disease, it's very known that it starts from Alois Alzheimer, from a histopathological study that he did in the brain of a patient that's suffering from dementia. He discovered two lesions, as has already described, the senile plaque and the neurofibrillary retangle. And it was the first time that Alzheimer has been mentioned. It took about 100 years to find the right technology in order to be able to detect these lesions in the brain. Also mentioned with better biological terms before, brain is connected with neurons, and there is the transmission, the signal on the neurons. And inside the brain, we can detect the dementia even 15 years before these symptoms, the first symptoms appears. So in this study, we are going to work with the most insenic plaque that is made by amyloid protein, and neurofibrillary retangle that is made from tau protein. In this study, we're trying to combine with another biomarker, the VEGF, the vascular endothelial growth factor, that is related with angiogenesis, and we are going to combine with Alzheimer's disease. When angiogenesis is needed, they call VEGF proteins. So VEGF proteins, they bind to VEGF receptors, and then some molecules attach to the receptors and the signal sent to endothelium in order the angiogenesis to start. So the cells, they start the cells with a capillary sprout, and then other cells are following, and inside the cells it starts to begin to become a lumen, and this is how angiogenesis is made. And here you can see live in aorta how angiogenesis is making. So based on this, so we can understand the role of angiogenesis. Physiological angiogenesis is involved in embryogenesis, wounded bone fracture healing, and in pathological angiogenesis, in case of increased angiogenesis, is related with different diseases such as atherosclerosis and inflammatory diseases, and in case of reduced angiogenesis, is associated with Alzheimer and cardiovascular disease. As we said at the beginning, Alzheimer's disease is impacting the individual's health and life and has a big impact worldwide, and as well the healthcare system. We know that Alzheimer's disease and VEGF-A have common pathological pathways like inflammation and angiogenesis. VEGF-A is a key biomarker that linked with different chronic disease. It has a genetic background and it's optimal for personalized medicine. And our hypothesis is that omics determinant of VEGF-A could be used for the risk prediction of common Alzheimer's disease. I have the chance to work in a laboratory that it has a long experience in VEGF. From the first GWAS study, they found 4 SNPs that they can explain more than 59% of the variability of VEGF. In the second GWAS study, we found 10 SNPs that they explain more than 52% of the variability of VEGF. So with this pool of SNPs, many studies, it was the base for many studies. And one of them I'm going to present today. From the biological methodology, the population that we have used, it was a case control of late onset Alzheimer's disease, a cross-sectional study that investigates the effect of ApoE and ApoE polymorphism on Alzheimer's disease. 1,078 individuals, 602 controls, 476 cases. The DNA extraction has been used, the Miller technique, and the genotyping has been, for the genotyping, we have used PCR chemistry and with the support of Randox. From the statistical part that I'm feeling more comfortable, okay, we have used some common methodologies like Spearman, Pearson for parametric, no-parametric analysis, a chi-square for categorical, MAF and Handy-Weinberg test to ensure the quality of our genetic data. For this study, as it was, we want to predict if a patient has or not Alzheimer, a binary metric. The most common thing is to use a logistic regression that probably most of you have already heard. Let's say that ElasticNet, it's a machine learning process. It's a scale-up. In place of using a logistic regression, to use something it's more accurate, and you avoid all the assumptions that it's not needed with logistic regression. As maybe just to make it clear, it's a machine learning approach. It's a part of artificial intelligence approach. But if we were in industry, for sure I will present it like an artificial intelligence process. But as we're in academic level, I will say that it's a machine learning process. It depends how you define artificial intelligence in any case. I will not go in details about the data process. I will be available if someone of you want to discuss in more details. Just to make it what it's maybe interesting on this process is that, as always has to do, is to separate the train and the test dataset. So the model that we made, it's made on the train dataset, and then when we have the model, we apply it on our test dataset. And at the end, when we standardize the model in order to be applied to other datasets, to other studies. The tools that they have been used, it's R software with some packages, specific packages of R, IPA for pathways analysis, and Microsoft Power BI. Although it's for business intelligence, it can be used in medicine, and maybe Microsoft in the future will create something for the medical field. Until today, it stayed in business field. This study has been published in Aging at the end. Personalized risk prediction model for why we do personalized risk prediction model for Alzheimer, because we want to show here that early prediction through genetic personalization can lead to appropriate prevention, early diagnosis, and appropriate management. The population that has used it was 323 individuals. The elastic net was the methodology. RStudio, the software that has been used. And we have used the 10 SNPs that was VEGF-related, and 2 SNPs related to LSR and ApoE polymorphism, and also the epistatic interactions between the SNPs. So from all this pool of SNPs, we put it on the model, but I will explain right after. We have 145 control, 182 control, 145 patients, almost around 78 years old, with the equivalence between male and female. From the quality control, one of the SNPs has been excluded. And so this is, at the left, you can see a plot, the outcome plot from ElasticNet. You are going to see it normally in the recent publications, as it's a new methodology the last years that has been used. So to implement this graph, at the left, there are some metrics. And these metrics, this model keeps the metrics that only impact the result if a patient has Alzheimer or not. So from a pool of 100 metrics, these are the most important. And if you see there is a 0 line. I don't know if you can see it here. Here it's a 0 line. And so the blue points that it's at the right, it has a positive impact. The blue points that it's at the left, it has a negative impact in the model. To simplify it, we can see that in this model, there has an impact risk factor variance like the ApoE and the interaction with ApoE and the age. And this is not something new, but it looks that our model, it works well. It was expected, this kind of results. From the other side, we can see here at the end of the model an interaction. It's also here that it has even bigger impact than the absence of ApoE. So, and also another interaction here that has almost the same impact with the absence of ApoE. ApoE, it's common that it's related with Alzheimer, but what is new here, it's the new 2 interactions that can predict with 72% of possibility the appearance of Alzheimer. So VEGF relate, and also these SNPs, as we said, it's related with VEGF-A. So the conclusion is that VEGF-A-related polymorphism are strong protective factors against Alzheimer's disease. And when I finalized this point, I was exciting, and I went to the professor and I said, okay, I find excellent results. We are ready. It's ready to publish. And they told me, okay, where is the biological approach? So I have to return back to have a biological approach. And then from the SNPs that they have been detected, we detect the genes that they relate with these SNPs. And from the pathway analysis, we found a direct interaction between VEGF-A and APP. And what does that it means? As VEGF-A, it's related with APP. It's all APP, we know that it's related with amyloid beta, and amyloid beta is related with senile plaque. Because in the surface of the neuron, there is some big proteins, the APP. Maybe it's known for you, but it was very interesting for me. And the enzymes, they are cutting APP, and then the amyloid beta is released to the brain. And this is a common process. But sometimes it's not cleared in the brain. So the amyloid beta attach each other, and then it's how the senile plaque is made. So that was the second part was the biological approach, and was a biological replication about the results. Today this study is patented by Randox Laboratories and is going to a replication phase. And we cross our fingers to be in the biggest population. If I have, I don't know if I have 2 minutes more, I have, okay. For this study, I have used 2 tools that maybe it will be interesting for you. The tools are very important in personalized medicine, especially because we need to visualize the data, and we need interactive dashboards in order to understand better our data. From any kind of level, from a student until, as I said, until director of hospital. So the first tool, it's the R. Normally it's known, a lot of people, they're using R software in order to do their analysis. On the top of that, it's the RSigny, that you can make an interactive interface. It's custom, it's a lot of coding needed, and it's hard to do it. But for those that are going to proceed as a computational biologist, it's a must-have. From the other side, it's the Microsoft Power BI, a tool that it's drag and drop, a quick way to do visualizations and share it with other people. And it doesn't need a lot of coding skills, and it's very good for managers from the industry, but also it's for professors in the academy. Just to give you a quick representation about this is the RSigny. It works. Okay. So this is the interface that has been made for this specific study in order to do our analysis. So we did it with our data set, but it can be, you can add it any data set in the future. And you just, when you upload a data set, it can separate the numerical variables, categorical variables, genetic variables, and you just specialize some information like to identify the predict variable and the ID. So when the data set is uploaded, then you can present the data. You have an overview of the data. This is the data set that we have used for the study. It's just a quick look to see if everything goes well. And then you go to a descriptive analysis, like a data summary. You have a summary of each metric that you use in the study. And also it's important to know about the missing values. Okay, how many we have, it's important, but if it's any pattern of missing values, it's important as well. And so that's why a lot of metrics have been excluded. Concerning the quality of the data, of genetic data, we can see that one SNP that is outside of the blue line has been excluded in this data set. Also, we can add some plots in order to see the categorical variables and the genetic variables between healthy and patients to have an overview of our dataset. And the same thing we can do with the continuous variable. With the violin plot, it's to see how the data are distributed. In general, before an analysis, we have to spend 70–80% on the data before do anything else. So, and this is the model that I have mentioned before, and I have already described how it works. The important thing, and I'm finishing with this part, the important thing is now you can add the data of a new patient, and it can give you the score of a prediction with 72% for Alzheimer's disease. So that's the one tool that has been used for the study. Also, a report can be made with all the graphs, and this is for our supervisors, for directors, to have a quick overview of what was your work, so a PDF report can be made. But all this, it was custom with R. And another one, it's the Power BI. As I said, I will be quicker on that. It's Power BI, it's a tool that it's drag and drop, it's much faster. And what is very interesting here is that all graphs are interactive. So whatever you need, whatever you want, you can, any filter that you choose, you can see directly your data that you have in your dataset. So I will be here in the next days. If you are interested for any of these tools to hear more, I will be here for you. So thank you for listening. Just before closing, I studied in the same building as a mathematician. It was the mathematics department here before it became biology. And I was in here, the photo it's from this side, I think. And after 10 years in France, I'm coming back thanks to Professor Drakoulis, that he was also in the jury of my thesis. And it was a nice journey returning back to talk to biologists, and I hope that it was clear from my side. Thanks a lot.
Thank you, Alexandros. Do we have any questions from the panelists?
Thank you very much. Computation biology is the future, so it's not clear for me if it is a complete platform, a complete tool that we can use it, or it is in a pilot mode, let's say.
The first one with RSINE, it's the pilot one, it's the pilot mode. And the second one, it's one that it's already the biggest part made by Microsoft, and you can use it directly.
Okay, so it's available. Okay, thank you very much.
Yes, Dr. Panagiotou.
Thanks for the talk, Alexandre. Really great introduction and amazing timing with your videos. I just wanted to ask, like, similar tools have been developed to predict Alzheimer's or other neurodegenerative diseases called polygenic risk scores. And I'm just curious how your methodology cross compares to polygenic risk scores. Is that something you've looked at or planning to?
For sure, other tools have been used. The reason that the first one, the first tool, as it's customized and it has the packages that is more adapted and more recent from medical research. So it's the first studies and the first packages, maybe you know what the first features that they are made. First, you can find it in R. And maybe after a few years, the industry will take it and you will see it in Power BI. For sure, there are other, you can do it similar with Python, other languages, but what is more adapted to your domain, to our domain, I think it's this one. It depends always the needs.
Yes, thank you. Any other question? I have a short question. As a clinician, do you give a certain report to a doctor who does not understand mathematics and just want to see how his patient is going to act or react to his medication? Do we have something written?
The idea at the end of it wasn't presented at the end of the first software. You need to have the genotype, you need to have some specific SNPs, and then if you have the values of the SNPs and the age, some additional variables, you can give a prediction with 72% accuracy if it's going to have Alzheimer or not. That's the idea.
So this can be used also as a as we have a blood test or something like that.
Yes, yes, it's yes.
And you have a number, and you say your patient is 95%.
Yes, yes.
With a problem or no problem.
It's 72% accuracy.
Okay.
And there's also 30% that has been to discover. And when the replication study will be done, because it's a bigger, much bigger population, I will come back to you.
Excellent. Thank you very much. Okay. If there is no other question, I would like to ask Dr. Panagiotou to come to the podium. He will tell us a very interesting about a very interesting test which is on the market now. I can say it like that. Pharmacogenetically guided treatment in major depressive disorder. I find this very, very important because I have to say for myself, I have been trying to do something like that the last 40 years. I'm very happy that it happened now in Greece, and we have a test where we can test our patients to see what is their pharmacogenetic profile, and according to this, we can give the correct medication to the correct dose. But I won't say anything more. You will hear everything from Nikos. Thank you very much.
Awesome. Okay. Thank you very much. Good evening, everyone. Initially, I would like to thank the organizing committee for inviting me to give this talk, and also I would like to thank you for staying this late into the day. So today I'm talking about pharmacogenetics and how we apply them in the real world, specifically for the treatment of mental health issues. And in this case, I'm going to speak mainly about depression. But whatever I say, it has to do with other mental disorders, such as psychosis or other events. And I'm just going to say I represent iDNA for this talk. So initially, I would like to start by saying that in Greece, at any given moment, it is estimated that maybe 1 million people are suffering from the symptoms of depression. And this number can even be twice as large, but we don't really have specific statistical evidence here in Greece. However, in Europe, we know that there is tens of millions of people suffering from depression. And these are patients that have chronic symptoms and all the side effects by their medications, absences from work, and there's a huge cost associated with this disease. So we need to ask nowadays, is there actually a need for a new approach to treat depressed patients? So I'm going to start by talking about antidepressant effectiveness. We know from a lot of clinical studies, but also from the clinical experience, that antidepressants have a delayed onset of action. 1/3 of patients do not respond during the first few weeks or months, and 2/3 of patients do not achieve remission. This means that the symptomatology doesn't go away. And the mean efficacy of all the treatments or of all the possible antidepressants in the market does not differ. We know that there is a lot of association of the antidepressants with tolerance and safety. So there is aggravation of anxiety, sleep disorders, gastrointestinal adverse events, sexual dysfunction, sedation, emotional blunting, and withdrawal symptoms. So obviously, because of all of these side effects that do happen to a lot of the patients taking the medication, there are issues with treatment adherence. So 42% discontinue their medication in the first month, and up to 70% discontinue in the first 3 months. So it's impossible for these patients that discontinue their treatment to actually achieve response and then remission. And 45% do not take the medication as recommended by the doctors. This means that they do not take the medication every day at the given times, or they miss days. So again, a lot of patients do not respond because of these issues. So yes, there is a need for a new approach. And this new approach is what we call precision medicine in mental health. So I want to paint you a picture of what happens nowadays. So nowadays we use what we call standard of care, or later you will hear me saying TAU, which stands for treatment as usual. So basically, these patients nowadays, they undergo a process. This is a trial and error process. So what this means is that the psychiatrist would prescribe a medication. The patients would be on the medication for a few weeks, maybe a few months, and if they don't respond, they might change to a different medication. And this can happen again and again over several periods of time. And this is why depression can be a chronic disorder. And as you can see here, with the treatment as usual, everyone is getting the same treatment at the same dose. And this is a big reason why these patients don't respond. So what we do, and what other people do around the world, and this is a very new field, we use pharmacogenetics to actually guide the treatment options that the physician chooses to prescribe to the patients. So with a pharmacogenetic test, we can actually subcategorize patients in distinct groups depending on how they metabolize drugs. So we can find the normal patients that can metabolize drugs normally, and they will respond to the normal dose, which is normally given. However, we have people that metabolize drugs very rapidly, so they would require a higher drug to achieve response. And then we have what we call intermediate metabolizers. So these are people that require lower doses. Otherwise, they would have a lot of adverse events. And finally, we have people that we call poor metabolizers. These people do not metabolize drugs well at all. So sometimes it might be required that they use a completely alternative medication, probably one that's metabolized by another pathway. So by doing this grouping, we can actually achieve precision medicine, and the psychiatrist or the neurologist, they can prescribe personalized drugs, and they can tailor the dose adjustment so that the patients respond. So what are the benefits of this approach? Initially, this is a personalized therapy, so it's an individualized drug selection and dose adjustment by the psychiatrists. With this way, we can achieve higher safety, so there's a reduction in the side effects because people are now capable of metabolizing the drugs at the right dose. And then the next step is that we are actually improving patient adherence, because these patients that do not develop adverse events as often as in the standard of care, they are much more likely to stay on the treatment for longer periods. So we can achieve speedier therapy, avoid the long periods of trial and error, and finally, we have improved the efficacy of the medication, so we can increase chances of treatment success, and there are higher remission rates. So how does that really look like in the real world? So initially, I'm showing you a clinical study that was done in 2019. So this was a 24-week double-blind randomized study in over 1,000 patients enrolled. And what we compare is the TAU, which is the treatment as usual, the trial and error process I mentioned, and the guided care is when the patients underwent a pharmacogenetic test. The psychiatrists took this into account, and then they prescribed the medication at the right dose depending on the pharmacogenetic test. So for depression, in all of the major categories, we see that the pharmacogenetic guided arm, they had higher symptom improvement and statistically significant higher response and remission rates. This is 8 weeks into the trial. So the pharmacogenetic test actually improved the outcomes in these patients. And I just want to show you that this is a continuous effect. So during the trial, the positive effect of the pharmacogenetic guidance continues to increase up to the 24-week period at the end of the trial. This is an even more recent study. This is a year-long, 52-week, double-blind randomized study, and it's also accompanied with a meta-analysis. This was done in Canada. And at the end of the year, although the patient number was small, we still see higher symptom improvement, higher response rate, and higher remission rates for all the patients that received the pharmacogenetic test at the start of the trial and had their medications personalized. And then there's also the associated meta-analysis with other clinical studies that shows a positive effect after pharmacogenetics. Okay, so this is like the clinical effects, but there is even more real needs for these people that suffer from depression, and we can use qualitative measures to actually see whether the pharmacogenetics have an effect. So we can look at quality of life, so there are tons of metrics, and we know that pharmacogenetics from similar studies, they improve quality of life. Metrics such as reduced absence from work, this is a very important one. And I'm going to talk more later about quality-adjusted life here. So basically what this means is that these tests improves the quality of life that people spend without symptoms, so longer time in their lives without disease. And then there's also associated costs with illness. By doing a pharmacogenetic test, we can actually reduce or avoid polypharmacy, so cost reduction. We can reduce failed drug trials, more cost savings, and reduction of clinical response time to treatment. So people get well sooner, so it means more cost savings. This is a study that I want to show you because of these qualitative measures. This was done in 2018, and it was based on a clinical trial, again, of 2018. So what I want you to look at here is that we have two columns. One is for the moderately severe depressed patients, and one is for the severely depressed patients. So the first outcomes that we look at is probability of death from suicides. Yes, these people tend to suicide, unfortunately, so this is a huge cost for society. So when we compare standard of care to the pharmacogenetic guidance, we can see that the guided arm, they have less suicides, and the QALYs, which I just mentioned, these are improved when pharmacogenetic test is involved in the equation. And these numbers are larger for the more severely depressed patients, so the benefits are larger for the more severely depressed category. And then about cost savings, again, this was done in Canada, so this was $2,598 saved in the moderately depressed patients, and close to $6,000 saved per patient at the end of the year for the really severely depressed patients. What we do nowadays in the clinical world is that we can do a pharmacogenetic test and we can provide recommendations. There's a ton of data and evidence that we can actually derive this information from. There's pharmacogenetic databases, pharmacogenetic consortia. Very important nowadays in the US, FDA, Switzerland here in Europe, and Korea, they all have pharmacogenetic associations in the drug labels that the drugs circulate in the market. So the information is there. And recently we even had medical guidelines in the Netherlands, which is really important. And specifically, this was the first guidelines, and they conclude by saying that when genotype information is available, use these, they mean to the psychiatrist or the neurologist, to select the right drug in the right dose for the right patient. So this is now clinical ground, so it's no longer just research and clinical trials, this is into the real world. And this is the most recent meta-analysis. It was done just a few months ago, and it clearly depicts a positive effect of pharmacogenetic guidance, both for remission and for response in depressed patients. So we actually do this here in Greece. We have developed this iDNA PGX-CNS test. This is done very simply. This box over there, it contains 2 buccal swabs, so we can collect the sample of saliva from the patient. This is sent to the lab, and the pharmacogenetic test is done, and then we give the report to the doctor, and then the doctor, depending on the results, they can pick the right drug, and they can make dose adjustments. And very recently, this test also gained reimbursement status by AOP, the National Healthcare System, so depressed patients can be reimbursed by doing this test. What this test looks at is very common to what other tests that the bibliography I showed you look at. So we look at 24 SNPs in 13 genes. These are associated with metabolism, side effects, or response to the medications. And we give evidence of associations with 30 central nervous system medications. And we look at antipsychotics and antidepressants that are given to patients that suffer from depression, but also other categories as well. And this is continuing updated by the new drug labels that circulate in the market or by new guidelines that come up and be published. Now I want to finish off this talk by giving you some data from Greece. We have actually done this research very recently. We have looked at 3,000 patients, psychiatric patients that we have tested here in Greece. You can see some of the demographics of this population, but I want to jump straight into the facts. So initially, we look at the cytochrome P450 genes because these are the genes associated with the metabolism of the most common antidepressants in the Greek market. And these are CYP2D6 and CYP2C19. For the first case, you can see in green, these are the normal metabolizers. So these people will respond well to the normal medication that the psychiatrist would give. However, there's a 30% of intermediate metabolizers. These people will require reduced dose, otherwise they will have side effects. And then we have the poor metabolizers, 4.5%. Again, these people require reduced dose or a completely alternative medication, maybe one other metabolized by the CYP2C19. And then the case is even more complex for the other cytochrome, because here we also have ultra-rapid metabolizers and rapid metabolizers. So if these people are given the normal dose, they will never respond because they metabolize it so quickly that they have no effect. So basically, these patients, they require higher doses in order to respond. Only 42% are normal metabolizers, and again, we have a 23.9% of intermediate and 2.1% of poor metabolizers. So obviously, overall, by identifying these patients, we can actually improve the therapy outcomes. Here is evidence from another gene, FKBP5. This is associated with the response to the antidepressants. So if you are in this group, you are much more likely to respond well to an antidepressant given. However, if you are in this group, you are less likely to respond well. And these patients with a reduced response genotype, they could benefit, for instance, from combinatorial therapy with an antipsychotic as well with an antidepressant. These data, they build up on previous research that we've done and published, and in smaller populations, initially in just 500 people and then 1,387. Where we also saw 60% with altered metabolism on the C19 and 38% of patients with altered D6 metabolism. So overall, there is about 70% of the patients, of the psychiatric patients that we have tested here in Greece, that presented either moderate or significant gene-drug interactions for a range of CNS drugs. And what this means is that their genotype could influence the metabolism and then the toxicity of these drugs. So personalized drug and dosage selection by the psychiatrist, it would definitely be beneficial to improve the safety profile of the medications and also improve response and remission rates by the patients. This is another study that we've actually asked the patients themselves after they received the pharmacogenetic guidance and the medication by their doctors for depression. And we see high numbers, 96% they managed to respond to the medication, 82% reported no serious side effects, 90% reported change in medication. So what this means is that after they did the pharmacogenetic test, they either switched to a different drug or the psychiatrist changed the dose of the medication they were receiving. And 87% they reported fewer physician visits. And I'm going to close this off. This is the case of Portugal. I talked about costs a little bit, so let's see what happens in Portugal and then here in Greece. So in Portugal, they actually estimated what's the cost of depression for the healthcare system. So the direct cost is about 30 million euros. And this is like medical appointments, drug prescriptions, and hospitalizations. However, there are the indirect costs, which is work productivity losses, absence from work, and suicide. And this was estimated to be just above 1 billion euros for 1 year. So this is a huge economic cost for society. So we actually did a cost-effectiveness analysis here in Greece. To do so, we devised this model where we compare pharmacogenetically guided treatment with treatment as usual. This is a tree diagram. It has all the potential treatment options and also the probabilities of the clinical outcomes. When I say clinical outcomes, I mean response rates, remissions, and suicides. And behind each point of this tree diagram, there is also associated costs of healthcare and medications. And at the end of the tree, there are outcomes and indicators such as quality-adjusted life years. So basically, when you run this tree 5,000 times doing simulations, you get this diagram. So basically, every dot in this diagram is one of these 5,000 simulations of the model that you do. So the more to the right that each simulation shows up, it means that the intervention is more effective than the standard of care. So all of the interventions are on the positive x-axis, so it means that every single simulation is more effective than standard of care. And then on the y-axis, we look at costs. So let's say 0.5% of the interventions are more costly and half are less costly. So all in all, what this actually means is that the pharmacogenetic test, it increases quality-adjusted life years, and there is an association of 55 euros per quality gained. So what this means is that if the healthcare system invests 55 euros per patient, this patient will gain 1 quality-adjusted life year. And this is actually really cost-effective, and the European median, to be acceptable, I think it's 17,000 euros. So when you are only 55 euros, you're good. And this is the map of the pharmacogenetic guidance. We initially get the metabolism profile, higher safety, more appropriate treatment, better adherence, faster response in order to achieve efficacy. And I would like to thank everyone.
Thank you very much. It's very hopeful there are some physicians that use pharmacogenetics in clinical practice. I would like to ask you if you have any feedback about after-sales results from the physicians.
I'm sure you have experience with this. I would say it's really tough to actually get feedback from physicians. We have done that for about 100 patients in the study I showed. But this requires a lot of effort and a big team to run this project. So we haven't done that yet, but absolutely I really want to do this. Thank you.
Okay.
Moving on with our next presentation from Mrs. Katerina Kaliandasi, member of the research group of clinical pharmacology and pharmacogenomics. Mrs. Kaliandasi will present us the frequency distribution of 2 SNPs in the MTHFR gene in patients with epilepsy.
So, hello. I'm going to present you my thesis about the frequency distribution of 2 polymorphisms of the MTHFR gene in patients with epilepsy. Firstly, we have to distinguish the epileptic seizure from epilepsy. A seizure is a transient occurrence of signs and symptoms due to abnormal excessive activity in the brain, whereas epilepsy is a brain disorder that is characterized by an enduring predisposition to generate epileptic seizures. According to International League Against Epilepsy, its definitions requires the occurrence of at least 1 epilepsy seizure. We have 2 types. In generalized epilepsy, the abnormal electrical activity that causes a seizure begins in both hemispheres of the brain, whereas in focal epilepsy, seizures arise from a specific part of the brain. There are plenty of symptoms like temporary confusion, staring spell, stiff muscles, uncontrollable jerking, loss of consciousness, and psychological symptoms like fear, for example, that a person may experience during a seizure. Concerning to the causes, here we have to think that we have a multifactorial disease. This may happen because of brain diseases like brain infections, or for example, meningitis, brain tumors, or brain hemorrhages. There are medications, of course, that affect brain function that are crucial to epilepsy development, like drugs, painkillers, or antibiotics. Lifestyle, like alcohol consumption, insomnia, and stress, are also significant for seizure development, and of course, genetics. There are many genes like ion transfer channels, neurotransmitters, and cell function affecting that play a crucial role in epilepsy. So, what if we could prevent or provide epilepsy considering DNA expression? The idea here is that by testing several genes and polymorphisms, we could find specific polymorphisms that could play a significant role in disease development. This concept may help doctors and researchers to predict and more accurately the prevention and treatment strategies for a particular disease. So, our study. In the spectrum of precision medicine and pharmacogenomics, we investigated the association between MTHFR polymorphisms and epilepsy development. But why MTHFR? So we have MTHFR gene that is located in chromosome 1, and this is responsible for methylene tetrahydrofolate reductase, a key enzyme in homocysteine pathway that is essential for DNA synthesis, DNA repair, and methylation of DNA. We have 2 main single nucleotide polymorphisms. The first one is C67717 exon 4 that results in a substitute of alanine to valine and results in a reduced enzyme activity. And the second one is A1298C in exon 7 that has a change in glutamic acid to alanine. This has also a lower enzyme activity, but not as severe as the previous one. In general, reduced MTHFR enzyme is connected with cardiovascular diseases, neural tube defects, neurodevelopmental and neuropsychiatric conditions, and even epilepsy. So, in our study, there were involved 214 patients with generalized or focal epilepsy, which were genotyped with Caspase for our 2 polymorphisms. The control group is comprised of 1,411 people of our database. All participants signed an informed consent for the study, and their samples were anonymized. Then there was a statistical analysis with Q-square test at the significance level of 0.05 via MedCalc software. our experimental procedure. Of course, we start with DNA extraction. After that, there is a PCR where we use specific primers and probes in order to amplify the genes of our interest. Our genotyping method is CASP assay that utilizes 2 competitive allele-specific forward primers and 1 common reverse primer. Each forward primer incorporates an additional tail sequence that corresponds with one of 2 Fred cassettes. So the fluorescent signal is then analyzed by using an appropriate software, giving us the ability to discriminate the SNPs. And our results. As you can see, the allelic frequencies as the genotypic frequencies for the polymorphism A1 to 98C are extremely similar to our controls group. So, as that it seems, there is no statistically significant result in correlation between this polymorphism and epilepsy, as the p-value is greater than 0.05. Also, our results for the C677T polymorphism, where the allelic frequencies as well as the genotypic frequencies are really close to each other. And so as it seems, there is no correlation again between this polymorphism and epilepsy, as the p-value was again greater than 0.05. But then we decided to divide our patients group in subgroups according to the seizure onset, because we just wanted to test the early onset of epilepsy seizures. And then, as you can see, we can see that there is an increase in frequency of the T allele. So there was a statistically significant correlation between this polymorphism and T allele between the patients and the control group, and as you can see, the T allele appears 1.6 times more often in patients comparing to the control group. So it seems that these polymorphisms of the MTHFR gene may not have an impact on epilepsy, although there needs to be further investigated the association of the C677T polymorphism with epilepsy patients with early seizure onset between 0 and 5 years old. Thank you for your attention.
Thank you, Mrs. Kaliadas, for the presentation. Any questions? No questions. Thank you very much. We're moving on with our next presentation from Dr. Timos Dimitrakis. Dr. Timos Dimitrakis is also a member of the research group of clinical pharmacology and pharmacogenomics, and he's going to present us the effect of polymorphisms in the VDR gene on the development of Alzheimer's disease in Greece.
First of all, I would like to thank Professor Dakoulis and the organizing committee for the invitation. I'm very happy to be here, and it's my honor to participate in this Congress. I will present to you the effect of vitamin D receptor gene single nucleotide polymorphisms on the development of Alzheimer's disease in Greece. And very briefly, I will go through some basic information about the disease and vitamin D that more or less all know. Oops, sorry. So, Alzheimer's disease is a type of dementia that affects memory, cognitive ability, and behavior. It's the most frequent type of dementia, approximately 70% of cases. The prevalence in Greece is estimated in about 1.4%, while the prevalence in people over the age of 70 is estimated from 9 to 10%. Based on the age of that the symptoms of the disease start, we have early onset Alzheimer's disease and late onset Alzheimer's disease. In this presentation, we are referring to late onset Alzheimer's disease. Basic symptoms: the progressive memory loss and the difficulty in concentrating and thinking, as well as the declining ability to take decisions and performing everyday tasks, as well as behavioral changes. In terms of neuropathology, in the microscopic level, the most characteristic features of the disease are the extracellular amyloid plaques and the intracellular amyloid plaques consisting of accumulation of the toxic amyloid beta protein and intracellular neurofibrillary tangles consisting of hyperphosphorylated beta protein. The synthesis, the production of the toxic amyloid B starts from the cleavage of APP protein or the amyloid B precursor protein with the effect of two enzymes, the beta and gamma secretase. Now for vitamin D, with the term vitamin D, we consider a group of fat-soluble molecules. They call this corticosteroids, with main representatives the molecule ergocalciferol or vitamin D2 and cholecalciferol or vitamin D3. It is produced from the exposure of the skin keratinocytes to ultraviolet radiation B, starting from the molecule of 7-dihydrocholesterol. And it is estimated that about 80% of the circulating vitamin D in the human body is produced in the skin. However, the form of the molecule that is produced in the skin is not the active form. We need two chemical reactions inside the human body, two hydroxylations, one in the liver and one in the kidneys, in order to the active form of the vitamin to be produced, the 1.25 2-hydroxy vitamin D or calcitriol. The classical actions of vitamin D, as you all know, are in the target organs of intestines, kidneys, and bones. Is the regulation of calcium and phosphate homeostasis together with parathormone. But in the last years, we have many information about the association of vitamin D levels with immune system function or risk of diseases like cancer, diabetes, and neurological disorders. The mechanism of action of vitamin D is relatively complicated. Its actions are divided in genomic and non-genomic actions. The genomic actions are mediated by the nuclear vitamin D receptor, which binds to the molecule of vitamin D, and together with another receptor, the retinoid X receptor, they form a complex which binds to specific DNA sequences and acts as a transcriptional factor, which means that regulates the expression of genes, either increasing or decreasing the expression of target genes. Now, specifically, the actions of vitamin D in Alzheimer's disease, in the last years, we have many information and data from experimental in vitro and in vivo studies indicating that it plays a very positive and beneficial role in neural sense in Alzheimer's disease. In terms of neurotoxicity, it increases the clearance of amyloid beta or decreases the accumulation of phosphorylated P tau proteins. And overall, most researchers agree that the neuroinflammation, neurotoxicity, and calcium homeostasis are highly affected by vitamin D in Alzheimer's disease, and overall providing neuroprotection. A very important mechanism of decreasing neurotoxicity is the decrease of the expression of beta and gamma secretases, which are involved in the cleavage of APP protein. These are the enzymes that actually produce the toxic amyloid beta. Now, the vitamin D receptor gene is located in chromosome 12. It consists of 11 exons. There have been reported 5 single nucleotide polymorphisms related to Alzheimer's disease in the VDR gene. The FOC1 and TAC1 polymorphisms are located in exon 9, while ABBA1, TRU91, and VSM1 are located in intron 8. These are named after the restriction enzyme which is used in order to detect them. Now, in the southeastern European Caucasian population, in which the Greek population belongs, it has been reported that the homozygous TT genotype in TAC1 polymorphism has been associated with 1.8 times higher risk for Alzheimer's disease, while the C allele has been associated with in the same polymorphism, the TAC1, has been associated with 1.8 times lower risk for developing the disease. When investigating the three polymorphisms, TAC1, BSM1, and FOC1, it has been reported for the same population, the southeastern European Caucasians, that TAC haplotype is associated with 6 times higher risk for Alzheimer's disease, while the CAC haplotype is associated with 50% lower risk for the disease. Specifically for women carrying the TAC haplotype of the southeastern European Caucasian population, the risk of developing Alzheimer's disease has been associated as 9 times higher in comparison to the control group. As a result, it has been suggested that the homozygous TT genotype in TAC1 polymorphism or the TAC haplotype may affect the utilization of vitamin D from the human body, and they have been suggested certain mechanisms either by decreasing the stability of VDR mRNA or by decreasing the binding affinity of the molecule of vitamin D to VDR, or by creating alternative VDR splicing products due to the proximity of TAC1 polymorphism to the binding point of intron 8 and exon 9, which leads to splicing products again with lower stability or mRNA stability. Overall, in the southeastern European and Caucasian population, the decreased vitamin D utilization that has been proposed due to the TAC haplotype or the TT genotype in TAC1 polymorphism actually deprives the neural system from the positive effects of vitamin D in terms of neuroprotection, neuroinflammation, amyloid B clearance, or tau hyperphosphorylation, and most importantly, deprives the regulation of beta and gamma secretases which are involved in the production of the toxic amyloid B, overall providing increased risk for Alzheimer's disease. More specifically, in women, the reduced vitamin D utilization has been associated with decreased expression of the estrogen receptor 1 and insulin-like growth factor 1. Both factors have been also associated with decreased neuroprotection. So as a result, in Greece, the VDR gene SNPs have been associated with the risk of Alzheimer's disease. However, additional studies are required in order to investigate the potential association of these SNPs with the serum levels of vitamin D in AD patients. But we have some evidence that serum levels of vitamin D might not act beneficially for AD patients due to the VDR gene SNPs and poor vitamin D utilization. Thank you.
Thank you, Dr. Dimitrakis. Any questions? No, thank you very much. So we're proceeding with our next presentation from Mrs. Andrea Michail. Mrs. Andrea Michail is going to present us the association of genetic polymorphisms in 3 genes in the treatment of patients with lithium-containing preparation.
Καλησπέρα. Αρχικά θα ήθελα να ευχαριστήσω τον κύριο Δρακούλη για την πρόσκληση. Θα μιλήσουμε για το ρόλο των γενετικών πολυμορφισμών στα γονίδια της COMT, PDNF και ANCA1 κατά τη θεραπεία ασθενών με σκευάσματα που περιέχουν λίθιο. Ξεκινήσουμε λίγο με τα αρχικά. Ως γενετικοί πολυμορφισμοί χαρακτηρίζονται αλλαγές στο γενετικό κώδικα που συμβαίνουν σε ποσοστό περισσότερο του 1% του πληθυσμού. Σημειακός νουκλεοτοειδικός πολυμορφισμός, ο ESNP, ορίζεται ως μία αλλαγή στην αλληλουχία του DNA μόνο σε ένα ζεύγος νουκλεοτιδίων. Τα SNPs χρησιμοποιούνται για τη μελέτη γενετικών διαφορών μεταξύ ατόμων και πληθυσμών και η εφαρμογή της ανάλυσης τους παρέχει πληροφορίες σχετικά με τα χαρακτηριστικά της κάθε ασθένειας, την κατάλληλη εφαρμογή θεραπείας, αλλά και την αντίσταση που μπορεί να παρουσιάσει οποιαδήποτε φαρμακευτική αγωγή. Το λίθιο, όπως όλοι γνωρίζουμε, εδώ και χρόνια έχει καθιερωθεί ως αποτελεσματικός παράγοντας στην αντιμετώπιση συναισθηματικών διαταραχών και χρησιμοποιείται κυρίως για τη θεραπεία διαταραχών διάθεσης, όπως η μανία, οι τακτικές περίοδοι κατάθλιψης και η διπολική διαταραχή. Σχετικά με το μηχανισμό δράσης του, βρέθηκε ότι βοηθά στην πρόληψη του κυταρικού εκφυλισμού λόγω αύξησης των επιπέδων BDNF και τα μειωμένα επίπεδα του BDNF παρουσιάζονται σε ασθενείς με διπολική μανία και οι πολυμορφισμοί στο συγκεκριμένο γονίδιο σχετίζονται με τον κίνδυνο για εμφάνιση διπολικής διαταραχής και την ανταπόκριση στη θεραπεία της διπολικής διαταραχής. Επίσης, ρυθμίζει τη δράση νευροδιαβιβαστών και συγκεκριμένα ασκεί ρυθμιστική επίδραση και εμποδίζει την υπερβολική απελευθέρωση της δοπαμίνης που προκαλεί την μανία. Επηρεάζει την νευροδιαβίβαση των κάπα και γλουταμινικού οξέως, τα οποία προκαλούν ανεβασμένα επίπεδα διάθεσης και προκαλεί εξασθένιση των καταθλιπτικών συμπεριφορών μέσω των χολινεργικών οδών. Στη συγκεκριμένη εργασία πραγματοποιήθηκε προσδιορισμός των πολυμορφισμών ενός νουκλεοτιδίου στα συγκεκριμένα γονίδια που σχετίζονται με ψυχικές διαταραχές ή και ανταπόκριση της στη θεραπεία με λίθιο από τις μελέτες που έχουν ήδη πραγματοποιηθεί στο παρελθόν. Χρησιμοποιήθηκε η βάση δεδομένων ESEMP, όπου παρήχε πληροφορίες σχετικά με τη συχνότητα κατανομής του κάθε αλληλόμορφου και του κάθε κονότυπου στους πληθυσμούς 4 υπήρων με τους συγκεκριμένους πολυμορφισμούς και ακολούθως έγινε προσπάθεια για συσχέτιση των αποτελεσμάτων με την ανταπόκριση των ασθενών στη θεραπεία με το λίθιο, με βάση τα όσα είναι πλέον γνωστά για τον μηχανισμό δράσης του. Οι πληθυσμοί που εξετάστηκαν ήταν πληθυσμός της Ανατολικής Ασίας, της Νότιας Ασίας, της Ευρώπης, της Αφρικής και της Αμερικής. Ξεκινώντας, το γονίδιο της COMT, η COMT αποτελεί συγκεκριμένα ένα ένζυμο που βοηθά στην απεικοδόμηση των κατεχολαμινών, όπως είναι η ντοπαμίνη, η επινεφρίνη και η νορεπινεφρίνη. Και το πιο γνωστός πολυμορφισμός ενός νουκλεοτιδίου είναι ο πολυμορφισμός VAL158MET, που προκύπτει από την αντικατάσταση του αμινοξέως βαλίνη από το αμινοξύ μεθιονίνη. Η αντικατάσταση αυτή προκαλεί διαφορετική ενεργότητα και αποτελεί την κυριότερη αιτία για την ποικιλόμορφη δράση του ενζύμου της COMT. Το VAL και το MET αλληλόμορφο συνδέονται με υψηλή και χαμηλή ενεργότητα στο ένζυμο αντίστοιχα. Συγκεκριμένα το VAL αλληλόμορφο συνδέεται με τον μεταβολισμό της δοπαμίνης, που είναι ως και 4 φορές πιο γρήγορος από ό,τι στην απουσία του πολυμορφισμού. Αντιθέτως, το MET αλληλόμορφο παρατηρείται μειωμένη λειτουργική δραστικότητα του ενζύμου, με αποτέλεσμα παρατηρούνται υψηλά επίπεδα ντοπαμίνης προσυναπτικά, που οδηγούν τελικά σε αυξημένη ντοπαμινεργική διέγερση στο μετασυνυπτικό νευρών. Η συσχέτιση του πολυμορφισμού ενός νουκλεοτιδίου RS4680 της COMT με διπολική διαταραχή και διαταραχές της διάθεσης γενικά αποδίδονται κυρίως στο αλληλόμορφο MET-α. Οπότε από τα αποτελέσματα μας βλέπουμε ότι το G αλληλόμορφο υπερτερίζει τη συχνότητα εμφάνισης έναντι του α αλληλόμορφου σε όλους τους πληθυσμούς που εξετάστηκαν. Ο γονότυπος Gen-G παρουσιάζει μεγαλύτερο ποσοστό κατανομής σε Αφρική και Ανατολική Ασία, ενώ ο γονότυπος AG σε Νότια Ασία, Ευρώπη και Αμερική. Αντιθέτως, ο γονότυπος ΑΑ παρουσιάζει το μικρότερο ποσοστό κατανομής σε όλους τους υποεξέταση πληθυσμούς. Οπότε, τα άτομα που παρουσιάζουν γονότυπο Gen-G υποθέτουμε ότι θα παρουσιάσουν χειρότερη ανταπόκριση στη θεραπεία με λίθιο εναντί των ατόμων με γονότυπο ΑΑ, αφού υπάρχει καλύτερη συσχέτιση του αλληλόμορφου Α και κατ' επέκταση του ομόζυγου γονότυπου ΑΑ με διαταραχές διάθεσης και κατά ανάγκη για λήψη θεραπείας με λίθιο. Ο εγκεφαλικός νευροτροφικός παράγοντας δρά κυρίως στο κεντρικό και παρασυμπαθητικό νευρικό σύστημα και συμβάλλει στη διατήρηση και την επιβίωση των υφιστάμενων νευρώνων, αλλά και στην ανάπτυξη των νέων. Στο γονίδιο του BDNF, ο πιο γνωστός και πολύ μελετημένος πολυμορφισμός ενός νουκλεοτιδίου είναι ο VAL66MET. Η παρουσία αυτού επηρεάζει την απελευθέρωση του BDNF από τους νευρώνες και το πιο κοινό αλληλόμορφο C κωδικοποιεί το VAL, ενώ το αλληλόμορφο TAF κωδικοποιεί το MET. Το VAL αλληλόμορφο σχετίζεται με υψηλότερη δραστηριότητα του συστήματος BDNF και οι πλήστες μελέτες αποδεικνύουν μια σύνδεση του αλληλόμορφου VAL με την προδιάθεση για διπολική ασθένεια. Από τους πληθυσμούς που εξετάστηκα, βλέπουμε ότι το αλληλόμορφο C κατανέμεται με μεγαλύτερη συχνότητα σχεδόν σε όλους τους πληθυσμούς και ο γονότυπος C παρουσιάζει το μεγαλύτερο ποσοστό εμφάνισης σε όλους τους υποεξέταση πληθυσμούς. Δεδομένου ότι το λίθιο είναι γνωστός ενισχυτής του συστήματος BDNF, υποθέτουμε ότι η θεραπευτική επίδραση του λιθίου θα μπορούσε να είναι καλύτερη σε ασθενείς με χαμηλότερη δραστηριότητα του συστήματος αυτού. Με βάση τα πιο πάνω αποτελέσματα, οι περισσότερες υποεξέταση ομάδες πληθυσμών θεωρητικά δεν θα είχαν καλή ανταπόκριση στη θεραπεία αμυλίθιου, αφού στο μεγαλύτερο ποσοστό των πληθυσμών εκφράζεται ο γονότυπος ΣΕΣΕ. Το γονίδιο ΑΝΚΑΠ1 είναι στενά συνδεδεμένο με τον ντοπαμινεργικό υποδοχέα και ο πιο γνωστός πολυμορφισμός ενός νουκλεοτιδίου είναι ο RS180497 του υποδοχέα αντίδιο της ντοπαμίνης. Στον λόγο πολυμορφισμό παρουσιάζεται το αλληλόμορφο J και το αλληλόμορφο Α. Το Α συνδέεται με χαμηλότερα επίπεδα ντοπαμίνης στον εγκέφαλο και θεωρείται ότι διαδραματίζει σημαντικό ρόλο στην εμφάνιση εθισμού από αλκοόλ και κάπνισμα και στην εμφάνιση ορισμένων νευροψυχιατρικών διαταραχών. Οι γονότυποι J-α και Α-α συνδέονται με χαμηλότερα επίπεδα υποδοχέων ντοπαμίνης που οδηγούν σε αυξημένη ντοπαμινεργική δραστηριότητα. Και επιπλέον συσχετίστηκαν ο ετερόζυγος γονότυπο J-α και το Α-αλληλόμορφο με αυξημένο κίνδυνο για διπολική διαταραχή. Οπότε στους πληθυσμούς βλέπουμε ότι το J-αλληλόμορφο κατανέμεται με τη μεγαλύτερη συχνότητα σε όλους τους πληθυσμούς, ενώ ο γονότυπος J-α σε αυξημένη κατανομή παρουσιάζεται στην Αφρική και στην Ανατολική Ασία, ενώ ο γονότυπος Α-α είναι μειωμένος σε όλους τους υποεξέταση πληθυσμούς. Δεδομένου ότι το λίθιο εμποδίζει την υπερβολική απελευθέρωση ντοπαμίνης, υποθέτουμε ότι η θεραπευτική επίδραση του λιθίου θα μπορούσε να είναι καλύτερη σε άτομα με γονότυπο Α-α ή J-α. Παρόλο που μέχρι σήμερα αναλύθηκε ένας μεγάλος αριθμός ασθενών με υψηλό αριθμό SMPs που πιθανόν να εμπλέκονται στην ανταπόκριση του λιθίου με θετικά ευρήματα, που υποδεικνύουν ότι η ανταπόκριση στο λίθιο είναι πολυγονιδιακή. Εν τούτοις, τα αποτελέσματα αυτά δεν καταφέραν μέχρι στιγμής να χρησιμοποιηθούν ευνοϊκά στην κλινική πράξη, διότι το λίθιο έχει πολύπλοκο μηχανισμό δράσης και στη θετική ανταπόκριση κατά τη θεραπεία με αυτό εμπλέκονται πάρα πολλά γονίδια. Συνοψίζοντας, παρατηρούμε ότι η πραγματοποίηση φαρμακογονιδιωματικής ανάλυσης αποτελεί απαραίτητο εργαλείο για την επαλήθευση του τρόπου με τον οποίο ένα ή περισσότερα φάρμακα μπορούν να δράσουν αποτελεσματικά σε κάθε ασθενή, προβλέποντας έτσι το προφίλ αποτελεσματικότητας και ασφάλειας κάθε φαρμάκου, προκειμένου να αυξηθεί η θεραπευτική επιτυχία και να μειωθούν οι υποτροπές και οι ανεπιθύμητες ενέργειες. Σας ευχαριστώ πάρα πολύ για την προσοχή σας.
Thank you very much. Any questions? Okay, thank you. Moving on with our last presentation from Mrs. Stavriana Pariou. Mrs. Stavriana Pariou is going to present us the study of single nucleotide polymorphism in patients with multiple sclerosis.
Καλησπέρα και από εμένα. Εγώ θα σας παρουσιάσω σήμερα ένα μέρος της μεταπτυχιακής μου εργασίας με τίτλο «Μελέτη σημειακών νουκλεοτιδικών πολυμορφισμών σε ασθενείς με πολλαπλή σκλήρυνση», η οποία εκπονήθηκε στο Εργαστήριο Κλινικής Φαρμακολογίας και Φαρμακογονιδιωματικής του Τμήματος Φαρμακευτικής του ΕΚΠΑ. Συνοπτικά, θα σας μιλήσω σήμερα με λίγα λόγια για την πολλαπλή σκλήρυνση, το σκοπό της παρούσας μελέτης, τον πληθυσμό της μελέτης, τη διαδικασία συλλογής και επεξεργασίας δειγμάτων, τη στατιστική ανάλυση των αποτελεσμάτων, για τα αποτελέσματα και τέλος τα συμπεράσματα που βγήκαν. Η σκλήρυνση κατά πλάκας ή πολλαπλή σκλήρυνση είναι μια χρόνια αυτοάνωση φλεγμονώδης νόσος που χαρακτηρίζεται από απομυελίνωση των νευρώνων και επηρεάζει τη λειτουργία του κεντρικού νευρικού συστήματος. Η νόσος εμφανίζεται πιο συχνά σε νεαρές γυναίκες κατά τη δεύτερη ή τρίτη δεκαετία της ζωής τους και επηρεάζει σημαντικά την ποιότητα αυτής. Συγκεκριμένα, οι γυναίκες εμφανίζουν 3 φορές πιο συχνά την νόσο σε σχέση με τους άντρες. Έχει υπολογιστεί πως περίπου 2,5 εκατομμύρια άνθρωποι παγκοσμίως πάσχουν από πολλαπλή σκλήρυνση. Κάθε άτομο που πάσχει από πολλαπλή σκλήρυνση επηρεάζεται διαφορετικά από την νόσο και μπορεί να εμφανίσει ένα ευρύ φάσμα συμπτωμάτων. Η πιο κοινή συμπτωματολογία είναι κούραση, προβλήματα όρασης, μούδιασμα, μυϊκή σπασμή και αδυναμία, κινητικά προβλήματα, πόνος, προβλήματα σκέψης, μάθησης και προγραμματισμού, κατάθλιψη και άγχος, γαστρεντερικά προβλήματα και δυσκολίες στην ομιλία και την κατάποση. Η αιτιολογία της πολλαπλής σκλήρυνσης παραμένει άγνωστη ως και σήμερα, όμως ο συνδυασμός ανοσολογικών διαταραχών μαζί με την επίδραση του περιβάλλοντος και την γενετική προδιάθεση φαίνεται ότι ενδέχεται να σχετίζονται με την ανάπτυξη της νόσου. Σκοπός μας υπήρξε η έβρεση γενετικών δικτών που να σχετίζονται με την εμφάνιση της νόσου ή την εκδήλωση συγκεκριμένων συμπτωμάτων. Έτσι, διερευνήθηκε η συχνότητα εμφάνισης συνολικά 3 σημειακών νουκλεοτιδικών πολυμορφισμών, τους οποίους και βλέπετε. Ο πρώτος είναι ο RS18-20795 του γονιδίου της συντερλευκίνης 6. Ο δεύτερος είναι ο πολυμορφισμός RS18-20629 του γονιδίου του TNF-α και ο τρίτος ο πολυμορφισμός RS6265 του γονιδίου του BDNF, ώστε να μελετηθεί το αν σχετίζονται ή όχι με την εμφάνιση της νόσου ή με τα συμπτώματα έναρξης αυτής. Στην παρούσα μελέτη συμμετείχαν 200 ασθενείς νοτιοανατολικής ευρωπαϊκής Καυκάσιας προέλευσης από την Ελλάδα, με πολλαπλή σκλήρυνση, άντρες και γυναίκες που παρακολουθήθηκαν στην νευρολογική κλινική του Πανεπιστημιακού Νοσοκομείου Λάρισσας και 207 μάρτυρες από τη βάση δεδομένων της ερευνητικής ομάδας κλινικής φαρμακολογίας και φαρμακογονιδιωματικής του Τμήματος Φαρμακευτικής του ΕΚΠ. Στον πίνακα 1 φαίνονται συνοπτικά τα διαθέσιμα δημογραφικά και κλινικά χαρακτηριστικά των ασθενών που συμπεριλήφθηκαν στην παρούσα μελέτη. Βλέπουμε ότι από τους 200 συνολικά ασθενείς, οι 144 ήταν γυναίκες και οι 56 άντρες. Η μέση τιμή της ηλικίας έναρξης της νόσου για τους ασθενείς αυτούς φαίνεται πως ήταν τα 33,8 έτη. Αντίστοιχα, η μέση τιμή της ηλικίας έναρξης για τις γυναίκες είναι τα 32,7 έτη και για τους άντρες τα 34,9. Όλοι οι ασθενείς διαγνώστηκαν με υποτροπιάζουσα διαλείπουσα πολλαπλή σκλήρυνση, που είναι και ο πιο κοινός τύπος της νόσου. Στα αγγλικά φαίνεται ως RRMS. Όσον αφορά τα συμπτώματα έναρξης, το πιο κοινό φαίνεται να είναι οι αιμωδίες, με ποσοστό 53%, και ακολουθούν η διαταραχή βάδισης και η μυϊκή αδυναμία, με ποσοστό περίπου 15%. Τα συμπτώματα χωρίστηκαν από εμάς σε 3 κατηγορίες: κινητικά, αισθητηριακά και προβλήματα όρασης. Για την ομάδα ελέγχου, στο σχήμα 1 παρουσιάζεται η κατανομή του ηλικιακού εύρους. Στην ομάδα ελέγχου συμπεριλήφθηκαν συνολικά 207 μη συγγενείς εθελοντές μάρτυρες. Οι γυναίκες ήταν 104 και οι άντρες 103 και η μέση τιμή της ηλικίας τους ήταν τα 34,8 έτη. Η διαδικασία που ακολουθήσαμε για την συλλογή και την επεξεργασία των δειγμάτων ήταν αρχικά δειγματοληψία αίματος, στη συνέχεια ανωνυμοποίηση των δειγμάτων και καταχώρηση μοναδικού κωδικού αριθμού για κάθε ένα από αυτά. Προχωρήσαμε στην απομόνωση του γενετικού υλικού, στη συνέχεια γονοτύπηση του DNA με τη μέθοδο της CAS-PCR σε θερμικό κυκλοποιητή Light Cycler 480. Και τέλος, τη στατιστική επεξεργασία των αποτελεσμάτων και εξαγωγή συμπερασμάτων για την πιθανή επίδραση των προς ανάλυση πολυμορφισμών στην πολλαπλή σκλήρυνση. Η στατιστική ανάλυση των αποτελεσμάτων χωρίστηκε σε 2 μέρη. Αρχικά πραγματοποιήθηκε στατιστική ανάλυση για τους υπομελέτη πολυμορφισμούς μεταξύ των πληθυσμών των ασθενών και των μαρτύρων και ακολούθησε η ανάλυση στις υποομάδες των ασθενών ως προς τα συμπτώματα εμφάνισης της νόσου, δηλαδή κινητικά, αισθητηριακά και προβλήματα όρασης. Για το πρώτο μέρος της στατιστικής ανάλυσης, αφού πραγματοποιήθηκε κατανομή των γονοτύπων για τους πολυμορφισμούς μεταξύ των πληθυσμών των ασθενών και των μαρτύρων, η ανάλυση της συχνότητας κατανομής των γονοτύπων και των αλληλομόρφων δεν έδειξε κανένα στατιστικά σημαντικό αποτέλεσμα για τους υπομελέτη πολυμορφισμούς, τόσο για τον πολυμορφισμό του γονιδίου της εντερλευκίνης 6, όσο και για τον πολυμορφισμό του γονιδίου του TNF-α, αλλά και του BDNF. Για το δεύτερο μέρος της στατιστικής ανάλυσης, αφού έγινε πάλι η κατανομή των γονοτύπων για τους πολυμορφισμούς μεταξύ των πληθυσμών των υποομάδων των ασθενών για τις 3 κατηγορίες συμπτωμάτων, η ανάλυση της συχνότητας κατανομής των γονοτύπων και των αλληλομόρφων για τον πολυμορφισμό του γονιδίου της εντερλευκίνης 6 έδειξε στατιστικά σημαντικό αποτέλεσμα για τους ασθενείς με κινητικά προβλήματα που φέρουν το μεταλλαγμένο αλληλόμορφο σε σχέση με αυτούς που δεν εμφανίζουν κινητικά προβλήματα, όπως φαίνεται με κόκκινο πλαίσιο. Κανένα άλλο στατιστικά σημαντικό αποτέλεσμα δεν εντοπίστηκε μεταξύ των υποομάδων των ασθενών για τους 2 άλλους πολυμορφισμούς. Στις 3 διαφάνειες που ακολουθούν, βλέπουμε την πρώτη από αυτές, φαίνεται συνοπτικά η βιβλιογραφική συσχέτιση των πολυμορφισμών με την νόσο. Σημειώνονται με κόκκινο πλαίσιο οι πηγές που μας φάνηκαν χρήσιμες και χρησιμοποιήθηκαν για την εξαγωγή συμπερασμάτων. Ναι. Συμπερασματικά, για τον πολυμορφισμό της συντερλευκίνης 6, δεν φαίνεται να υπάρχει συσχέτιση μεταξύ του πολυμορφισμού αυτού και της εμφάνισης της νόσου, αποτελέσματα αντίθετα με τα ευρήματα της μελέτης σε πληθυσμό τσέχικης καταγωγής, Μπενεσόβα et al. Του 2018, όπου παρατηρήθηκε συσχέτιση του πολυμορφισμού με την εμφάνιση της νόσου. Όσον αφορά τη συσχέτιση των συμπτωμάτων, τα αποτελέσματα έδειξαν πως οι ασθενείς με κινητικά προβλήματα έχουν περίπου 4 φορές περισσότερες πιθανότητες να έχουν ομοζυγία για το μεταλλαγμένο αλληλόμορφο σε σχέση με ασθενείς που δεν εκδηλώνουν κινητικά προβλήματα ως συμπτώματα έναρξης της νόσου. Η συσχέτιση των κινητικών συμπτωμάτων με την ιντερλευκίνη 6 και τον συγκεκριμένο πολυμορφισμό γίνεται πρώτη φορά μέσω της παρούσας μελέτης σε ασθενείς με πολλαπλή σκλήρυνση. Παρ' όλα αυτά, έχει υπάρξει συσχέτιση στο παρελθόν μεταξύ της ιντερλευκίνης 6 και κινητικών συμπτωμάτων σε άλλες νευρολογικές παθήσεις, όπως είναι το Πάρκινσον και η νόσος του Χάντινγκτον. Για τον πολυμορφισμό του γονιδίου του TNF-α, τα αποτελέσματα της παρούσας μελέτης έδειξαν πως δεν υπάρχει συσχέτιση μεταξύ του πολυμορφισμού και της εμφάνισης της νόσου, συμφωνώντας με τα ευρήματα της μελέτης Μυρόσκα et al. Του 2011, περί μη συσχέτισης και σε άλλους πληθυσμούς ιρανικής, βουλγαρικής, τουρκικής και πολωνικής καταγωγής. Ομοίως για τον πολυμορφισμό του γονιδίου του BDNF, τα αποτελέσματα έδειξαν πως δεν υπάρχει συσχέτιση μεταξύ του πολυμορφισμού και της εμφάνισης της νόσου, ούτε κάποια συσχέτιση με τα συμπτώματα. Κλείνοντας, περαιτέρω μελέτες σε μεγαλύτερο δείγμα πληθυσμού απαιτούνται για να επιβεβαιώσουν τα ευρήματα της παρούσας μελέτης και να παρέχουν επιπρόσθετες πληροφορίες αναφορικά με το ρόλο των υπομελέτη πολυμορφισμών στην εμφάνιση της πολλαπλής σκλήρυνσης και στην εκδήλωση των συμπτωμάτων, λαμβάνοντας υπόψη αλληλεπιδράσεις μεταξύ και άλλων γονιδίων, αλλά και μεταξύ γονιδίων και περιβάλλοντος. Σας ευχαριστώ πολύ.
Ευχαριστούμε, κυρία Πάρη. Υπάρχει κάποια ερώτηση από το κοινό? Οκ. Ευχαριστούμε πάρα πολύ. Λοιπόν, σήμερα κλείνει. Now we close. It is said in English so that everybody knows that we close the session today. For today, we meet tomorrow morning, 9 o'clock here, starting for the second very interesting day about infections, a very long session about infections. And then also one more session for dermatology is tomorrow. Yes, right. So have a nice evening. Thank you very much for being here. Goodbye.